Good morning and welcome everyone to the fifth meeting of the Joint Interim Standing Committee on Health and Human Services for the 2023-2024 interim. Madam Secretary, please proceed to call the roll.
Senator Nguyen? Senator Titus?
Here.
Assemblywoman Brown-May?
Here.
Assemblyman Gray? Assemblyman Hibbets?
Here.
Assemblyman Nguyen?
Here.
Vice Chair Orentlicker?
Here.
Chair Danyate?
And I'm here. Please mark Assemblyman Gray and Senator Nguyen excused. Assemblyman Gray should be here in a few minutes, so when he's present, please mark him present. Good morning, everyone, and welcome again to our Joint Committee on Health and Human Services. Today is a very exciting meeting. We're going to be talking about children's behavioral health, which I'm sure there's a lot of folks that are gladly interested in. It is pre-primary day, pre-primary election eve, close enough. So for folks who haven't voted, we obviously encourage everyone to please do so before tomorrow, as tomorrow is primary election day. We have a few folks slated throughout the day, and it should be a very good presentation. We have a lot of good presentations scheduled throughout the day, and so we encourage folks to please participate. I do have a few housekeeping items. First and foremost, before we begin, I'd like to remind everyone to please silence all electronic devices, especially cell phones and laptops, during the meeting. For members joining online, please mute your microphone when you are not speaking, but leave your camera on. Additionally, I ask our presenters on the Zoom video call to leave your cameras off and microphones muted until I call up the agenda item under which you are present. The Zoom video call has a chat feature. However, this is only to be used for technical assistance. And as a reminder, agenda items may be taken in a different order than listed, or two or more agenda items may be combined. The committee's meeting materials can be found on the Nevada Legislature's website, and you can also sign up for electronic notifications related to any activity on the committee's website. And if you wish to testify in person, please sign in at the table by the door and leave a business card. And if you do not wish to testify, we also ask that you sign in so we have a track record of who is here. When testifying in person, please turn the microphones on to speak and off to listen. And with that, we'll go ahead and begin public comment. So we'll go ahead and open public comment, which will be limited to 2 minutes per speaker. We asked folks that staff will time each speaker during public comment so that everyone has a fair opportunity to speak. In addition to testifying in person, members of the public may provide public comment in various other ways, including by written notification. And so we'll go ahead and start public comment here in Southern Nevada, and then we'll move up to Carson City. So if you are here for public comment, please proceed forward, and then we'll begin here.
Good morning, Chair Danyate and committee members. My name is Michelle Paul. I'm a psychologist and Assistant Vice President of Mental and Behavioral Health Training at UNLV, and the Executive Director of UNLV Practice, a community mental health training clinic. As a member of the Children's Mental Health Action Coalition, I represent our support for investment in mental health training programs. Nevada faces a shortage of mental health professionals, with existing programs focused primarily on adults. We need more child-focused mental and developmental health training programs. We propose a tiered and integrated system to develop a child-centric workforce skilled in prevention, early identification, assessment, and intervention. This would involve a curriculum from bachelor's to doctoral levels, sequential and graded in complexity, including whole child assessment, evidence-based practices, developmental considerations, trauma-informed care, systems integration, and cultural responsiveness. We ask for funding to support bachelor's level training for prevention and early intervention, and to expand master's and doctoral programs, including internships and postdoctoral fellowships. Currently, for example, Nevada has 0 accredited psychology doctoral internships for children, forcing the few trainees we do have to leave the state. Incentives for licensed providers to pursue professional development in child mental health would also help enhance skills and willingness to work with our most vulnerable. With funding, we can readily leverage existing resources, which include the motivation, talent, and expertise within the Nevada system of higher education, not only at UNLV, but among our other institutions, including, just for example, our colleagues at Great Basin College and Nevada State University. Expanding our mental health training programs with a focus on children's needs will develop the qualified workforce needed to support Nevada's youth. Thank you.
Good morning, Chair, Vice Chair, and Committee et al. My name is Damon Schilling, D-A-M-O-N-S-C-H-I-L-L-I-N-G, and I am the Director of Government Relations for Intermountain Health. I'm here today to speak to you on agenda items 5, 6, and 7. We commend the state and this committee for the focus on this much-needed area in healthcare for our children. We too have a focus on children's comprehensive health. We look forward to working with the state, this committee, our fellow healthcare systems, and members of the community like the Children's Advocacy Alliance and others to fill the gaps and help provide world-class healthcare for the children and families of Nevada. Thank you.
Good morning, Chair and committee members. I'm Stephen Benning, S-T-E-P-H-E-N, B as in boy, E-N-N-I-N-G, a psychologist and director of clinical training for UNLV's Clinical Psychology PhD program. I'm pleased to speak in support of the Children's Mental Health Action Coalition's request to the legislature in item 6. In particular, I speak to the need for greater opportunities for graduate training and for early assessment for common mental health and developmental disorders. Our doctoral training program brings in students from around the world to train in providing psychological services. However, our students must often seek internships outside of Nevada to complete their doctoral training. As a result, Nevada loses them and their clinical skills. Having additional funding to finish students' internship training in Nevada would keep them in our workforce, as would funding postdoctoral training that would prepare students for their careers in Nevada. Furthermore, funding an array of mental health training programs at the bachelor's and master's level would broaden the professional base of service providers to children. Each year, these programs could train around 10 times the number of providers more than our clinical psychology program can. Psychology's assessment competency provides mechanisms for identifying children with attention deficit hyperactivity disorder, specific learning disorder, intellectual development disorder, and other neurodevelopmental conditions. With legislative support, our profession could provide early screening and assessment of these conditions that would guide interventions that allow such children to find their full potential. With your support, we can improve the mental health training landscape of Nevada and support children who need our help most. Thank you.
Thank you, Chair and members of the committee, for the opportunity to speak today. My name is Will Rucker, W-I-L-L-R-U-C-K-E-R, and I am the Director of Community Health for Intermountain Health here in Nevada. As a not-for-profit healthcare system, we strongly support the Children's Advocacy Alliance's recommendations addressing child mental health priorities. Our recent community health needs assessment highlighted critical gaps in pediatric health services that these recommendations directly address. Implementing these recommendations is crucial for effectively enhancing the health and well-being of our children. Our vision at Intermountain Health is to be a model health system by providing extraordinary care and superior service at an affordable cost. Rooted in our values of clinical excellence, empathy, and collaboration, we believe in partnering with our communities to ensure every child has access to the care they need. Supporting these recommendations is not only the right thing to do, but it demonstrates the truth that we are, in fact, better together. Thank you for your consideration.
Good morning, Chair Donate and members of the committee. My name is Rebecca Acosta, and today I'm speaking to you as a member of Act for Kids Nevada, a group of parents and healthcare professionals advocating for comprehensive pediatric healthcare in our state, beginning with a standalone children's hospital. As a voice for families and advocates for the health and well-being of all children, Act for Kids understands that collaboration with healthcare providers and health systems is crucial to our efforts. Today, we are pleased to present a letter of community support endorsed by over 20 youth-serving organizations, as well as a policy recommendation to create a statewide task force. Detailed in our letter are actions we believe will move Nevada closer to having comprehensive pediatric health care, such as increasing insurance reimbursement rates, building provider recruitment and retention programs, streamlining licensure applications, and reviewing the scope of practice requirements for physician assistants and nurse practitioners. The proposed task force would identify obstacles to having a standalone, comprehensive children's hospital, develop policy recommendations to solve those challenges, and report back to this committee in summer 2026, allowing ample time for actionable changes in the 2027 legislative session. Led by patients and families, the task force would bring together key stakeholders in pediatric healthcare delivery to ensure collaborative efforts that best meet the needs of our most vulnerable population, our children. Families and providers across Nevada are sharing their stories with us. Family stories start similarly, praising the great providers we have here in our state, but then asking for more resources, more specialists, and more coordinated care. Providers echo these family sentiments, calling for comprehensive care for all of Nevada's children. I would like to end my public comment today with 2 quotes from one of our families. Our children's surgeon is great. However, he is limited in what he can do for our child because the pediatric infrastructure is not here. And from a medical provider, we are often referring children out of state now because some specialists have a 3-year wait list. Thank you for your time today.
Good morning, Chair and members of the Joint Interim Standing Committee on Health and Human Services. My name is Magdalena Ruiz, Magdalena Ruiz. I am the Family Peer Support Services Program Director at Nevada PEP. Family peer support services are crucial for helping families address the behavioral health needs of their children. Each month, we support over 500 families of children with autism, emotional disturbance, ADHD, and intellectual disabilities who have behavioral health care needs. Unfortunately, the families we serve report significant challenges to accessing the behavioral health services their child needs. The most frequent concern we hear from parents is waiting lists for assessments and services. We know that youth outcomes are much better in communities that have a robust service array, which includes emergency and planned respite care, in-home intensive services, family and youth peer support, and step-down programs. Currently, in Nevada, we have a very limited service array as documented in the Department of Justice investigation. This lack of services leads to over-reliance on residential treatment and poor outcomes for Nevada's youth and their families. Your support to improve Nevada's behavioral health care is urgently needed. Thank you.
Good morning, Chairman Donate and members of the HHS Interim Committee. My name is Shauna Tello. I'm the Academic and External Affairs Administrator at University Medical Center. I'm here speaking on behalf of the Child Mental Health Action Coalition Insurance Subgroup to discuss opportunities to improve access and delivery of mental health care for Nevada's children. The coalition has highlighted a few key items for your attention. We've also submitted a letter for your review. Areas of focus include early assessment and treatment for certain mental health diagnoses, easing administrative burden for prior authorization, aligning reimbursement rates with the national average, and fair expectations for submitting claims. Although I'm here representing our coalition, I'm also representing my family and the barriers we have personally experienced when trying to receive mental health services here in Nevada. I'll share with you our history. My grandfather was diagnosed with schizophrenia at age 42 and committed suicide. I'm also a parent of an adult with a mental health diagnosis. My daughter did not choose her illness. She was an honor roll student. She graduated at the top of her class, was accepted to Cornell University, and went on to attend St. Mary's on a full scholarship. Stress, environmental factors, and genetics were the perfect storm for her mental break. To put things in perspective, mental illness is a medical condition just like hypertension, diabetes, and cancer. These individuals have significant challenges that impair their ability to think and cope. Daily challenges can be overwhelming. This can also lead to substance use disorders. There's stigma and shame that creates embarrassment and reluctance to seek and receive help. There's also a need to expand some infrastructure here, more acute care setting, transitional subacute care coordination, and therapy. I want to share with you that last week my daughter was discharged from the hospital and not able to get her psych meds that she was taking while hospitalized due to prior authorization requirements. I attempted to purchase her meds. It would have cost me $1,400 for a 30-day supply. From a parent's perspective, I ask, how will my daughter navigate this system on her own when I'm no longer here? Will there be services for her, or will she become homeless? Will my daughter be treated with dignity and respect despite her illness? Establishing a system of care that prioritizes availability of resources and adequate insurance coverage will not only provide optimal outcomes for our children, but also uplift the well-being of the families overall that care for them. Finally, Las Vegas is fortunate to have you all as incredible leaders in our organizations and our community that are remaining steadfast to design a system to care for this population. Thank you all for your leadership, and God bless.
Hi, for the record, my name is Brandon Ford, BRANDONFORD. I'm a healthcare consultant from Best Practices Nevada. Thank you for this opportunity to present our recommendations to address the barriers related to insurance coverage of behavioral and mental health pediatric disorders in Nevada. Here are the key points that we propose will help. First, we urge a reduction in the burden of prior authorizations. Many providers are choosing not to take Medicaid and other plans because they do not feel it is worth the headache. The current multi-step process is lengthy and uncompensated. Streamlining this process or supporting legislation for reimbursement of these administrative costs is crucial. Simplifying this process will allow providers to focus on delivering care over paperwork. This in turn will increase provider retention and recruitment into these networks. Second, we call for expanded coverages related to the screening, diagnosis, and treatment of common neurodevelopmental disorders such as FAS, autism, and other learning and intellectual disabilities. Timely and proper treatment hinges on the ability to test for and diagnose these conditions without restrictions. I know providers in the community that had waiting lists over 6 months long for testing and never could keep up with the paperwork required to do so. Lastly, we propose establishing insurance overpayment recovery laws. Many of the surrounding states have laws that set limits, where our providers face recoupments for years after the services have been delivered and paid for. Punitive audits can lead to practices closing their doors and increase the provider shortage. I know providers being audited for minor technicalities in their documentation for services performed years ago. Setting reasonable time limits and rules will protect providers from unjust financial penalties and ensure a stable healthcare environment. Implementing these recommendations will significantly enhance access to behavioral and mental health services for children, alleviate administrative burdens on providers, and attract more healthcare professionals to serve in our community. We are grateful for your time and attention to children's mental health in Nevada, and we hope you will consider some of these steps towards improvement. Thank you.
Good morning. Mr. Chair, members of the Interim Committee on Health and Human Services. For the record, my name is Tammy Hansler. I'm the CEO and State Director for Communities and Schools of Nevada, the state's largest and most effective evidence-based stay-in-school organization. We serve more than 100,000 students across the state. As this group of distinguished policymakers knows, Nevada's mental and behavioral sector faces a supply and demand problem. When you look at the need in our youth, the problem becomes even more acute with the U.S. Surgeon General declaring it a national emergency, and Nevada's ranking at 51st in youth mental health access and services. The opportunity that presents us is to be innovative, collaborative, and agile in how we respond to that reality. There is a third dimension to supply and demand, and that is at the pace at which we will address this challenge. To wait until we have the necessary licensed personnel will simply take too long. We cannot therapy our way out of the problem. So how do we address the supply and demand urgency? Through cost-effective, non-clinical interventions that alleviate the suffering of our young people that they are experiencing right now in our schools each and every day. Those include activities and programs that promote good health, peer support, training caring adults with certain skills, and screening and facilitating referrals to community-based services for more intensive treatment. The Communities and Schools model of integrated student supports and the developmental relationship frameworks that our site coordinators are trained on is an example of a non-clinical intervention. It has a proven track record, and it's scalable through public and private partnerships. With our program in close to 120 Title I and high-need schools across Nevada, our trained full-time site coordinators are weaving community, brokering resources, and improving campus climate and culture to create a sense of belonging for our students. At CIS, we often see the compounding efforts that poverty has on the mental and behavioral health of our children, our students. With chronic stressors in their household, community and educational environments, coupled with the lack of resources to mitigate those stressors, our students are often showing up to school with a host of emotional challenges. Through a variety of campus-wide initiatives, small group interventions, and individual case management, our site coordinators equip students with the skills and resources they need.
If you can finish up your comments, please.
They need to manage their own mental and behavioral health. I thank the committee for your time to offer public comment today and for all the good work and deliberation you are doing on behalf of Nevada's children and families. Thank you.
Good morning. My name is Stacy Sasso. I'm the Executive Director of the Health Services Coalition. The Coalition is a member organization representing 25 union and employer-sponsored self-funded health plans in Southern Nevada, providing coverage to over 280,000 lives. Our membership includes hospitality workers, including MGM, Culinary Health Fund, and Boyd Gaming, construction trades, including plumbers and pipe fitters and Teamsters, public safety, and municipalities such as Clark County and City of Henderson. We're also members of the Children's Mental Health Action Coalition. The coalition is very supportive of expansion of access to mental health care providers in Nevada for our children. Nevada needs additional graduate training programs, and we support Nevada and the federal government investing those at community nonprofit settings. Providing these programs in nonprofit academic settings help keep providers in the state post-training and can keep the focus on care. Providing additional access will assist many families currently struggling with mental health and behavioral health issues. The creation of the Office of Children's Mental Health might help provide accountability, consistency, and coordination of help families navigate the many issues regarding mental health access in Nevada. I want to thank you for your time that you've dedicated today to review child mental health care in Nevada. This is an important topic for our members and the participants they represent.
Good morning, Chairman Dunyate and committee members. My name is Maya Holmes. I'm the Health Policy Director for the Culinary Health Fund. We're so pleased that the Interim Health Committee today and others like the Children's Mental Health Action Coalition are taking such focus and effort and care to address the behavioral and mental health needs of Nevada's youth. We all know mental health services are a critical need in our state, especially for our kids. Youth mental health in Nevada is in dire need of long-term and sustainable focus, resources, and accountability. We are members of the Health Service Coalition and echo their comments. We support efforts to grow and build the youth mental health workforce, streamline streamline the licensing process for mental health professionals and create new educational opportunities at the undergraduate level. We know UNLV is doing tremendous work in this area, which is exciting and needs support. I also wanted to address another issue that's non-mental health related on the agenda today. It's item 10. It's a little in the weeds, but on your agenda, it's pertaining to the statutorily required update on the implementation of Assembly Bill 7, adoption of the framework and regulations for the interoperability of health information. We closely followed AB 7 through the Patient Protection Commission in the 2023 legislative session. The goal of AB 7 was to require electronic health record interoperability consistent with national standards and best practices and ensure that patients can access their electronic health records directly from their providers and forward that information electronically. We're concerned that the proposed regulations for AB 7 indicate that compliance for covered parties is based on either maintaining an electronic health record system that meets specified interoperability standards or maintaining a connection with a health information exchange. A connection to a health information exchange should not be an alternative to having an interoperable health record system. We believe this provision in the draft regulations conflicts with the provisions of Section 1.08 in AB 7, which require the department to establish standards that allow patients to directly access their electronic health records and forward that information electronically. So essentially, AB 7 did not have a provision stating providers can use health information exchange connection to be compliant, so we do not understand why such a connection is an alternative to having an interoperable electronic health system in the regulations. It will prevent patient access, which is the basis of the law. So thank you.
Good morning. Good morning, Chair Giannante and members of the committee. My name is Leanne McAllister. I am the Executive Director of the Nevada chapter of the American Academy of Pediatrics. As you know, and as you've heard this morning, children and teens and their families are facing a lot of stress and challenges to mental wellness. And while some families can navigate routine stress, it's not uncommon for Nevada families, including mine, to incorporate mental health professionals into their healthcare routine. Mental health care is basic health care and encompasses a full range of pediatric mental and behavioral health services across multiple settings, at home, at school, and at the child's medical home with their pediatrician. The Nevada AAP advocates for policies that support a comprehensive approach to children's mental health that addresses prevention, early treatment, and crisis response. In the letter that I've submitted today, I've highlighted several policies that the AAP believes are pragmatic, feasible, and will have an impact on youth mental health for our state. For now, I'll just highlight two. To reduce the suicide rate, we're advocating for waiting periods for firearm purchases. The Nevada AAP is also advocating for later school start times to address the sleep deprivation health crisis that is leading to damaging chronic problems such as obesity, hypertension, headaches, irritability, difficulty concentrating, poor school and poor sport performance, dangerous driving, and depression. I am looking forward to hearing today's presentations. Thank you.
Thank you so much. Anyone else in Southern Nevada? Anyone in Carson City? I don't see anyone come to the table.
Mr. Chair, we do have somebody coming.
Yep. Please step forward, and you may begin.
Thank you. Thank you for the opportunity to give public comment today. My name is Carissa Pierce, and I am the Health Policy Manager with the Children's Advocacy Alliance. You've heard a lot about groups that we are supporting, and we've made a mental health coalition to try to address some of issues. And so this sheet is over at our table up here that we submitted. We also submitted a few letters. So thank you for the opportunity to submit recommendations. As you have heard, and many of our stories today support the need for better services for mental health, and They're all outlined in our recommendations, but we especially want to highlight the desire for a streamlined behavioral health board. This will reduce the administrative burden on the individual boards, who are often staffed with only 1 or 2 people who are burdened with supporting the licensure and renewals for the state. So we feel a single board would support and expand professional development opportunities for professionals in the state. So thank you again for the opportunity to give public comment.
Thank you so much. Anyone else in Carson City? BPS, is there anyone virtually?
If you'd like to participate in public comment, please press star 9 on your phone to take your place in the queue. Caller, you're unmuted and you may begin.
Good morning, Chair and members of the Joint Interim Standing Committee on Health and Human Services. My name is Carly Murray, that's CarleyMurray, and I am the Statewide Family Network Director at Nevada PEP. I'm also the parent of a youth with behavioral health care challenges. The Statewide Family Network program at Nevada PEP, funded by the Substance Abuse and Mental Health Services Administration, or SAMHSA, is charged with ensuring that family and youth involvement is incorporated in decision-making in system-level policies, procedures, and priorities for the children's mental health systems of care. We also work to improve the systems that serve children, youth, and families as a partner in Nevada's System of Care grant operated by DCFS. Family involvement is important when talking about issues surrounding children's mental health or when trying to improve systems because they are the individuals who need and receive the services and supports. They know if the services work, if the services are difficult to access, and how long they have waited for a service. Families know the policy and funding barriers that have kept their child from receiving the services they need. You can read through the Department of Justice investigation and see how families and youth with behavioral health challenges experience a system of care in Nevada. Their knowledge and expertise should help guide the necessary reform efforts in our state. Thank you.
Caller, you're unmuted and you may begin.
Thank you. Good morning, Chair and members of the Joint Interim Standing Committee in Health and Human Services. My name is Britt Young. I am a parent of a child with multiple disabilities and mental health needs. I am also the Statewide Family Network Coordinator at Nevada PEP. We know that a broad array of community-based services help to identify mental health concerns at an early stage, which reduces the need for crisis intervention and hospitalization and residential treatment. Investing in community-based children's behavioral health services benefits families, alleviates the burden on emergency services, and reduces the overall cost of mental health care while keeping children close to home. Today, I want to shed light on the needs of children, youth, and their families in rural communities in assessing mental health services. Families report that they must travel out of their communities to access services, or they are on wait lists that are months long. And when telehealth is the only option, unreliable internet can impede access to necessary care. The system of care philosophy in the foundation of children's mental health service delivery and includes the core values of family and youth-driven, community-based, and culturally and linguistically competent services. Nevada should develop solutions that are built on these nationally recognized core values in frontier rural, and urban areas of the state. Thank you for your time and the investments that you can make can be lasting positive impacts on their future.
If you've recently joined the call and would like to participate in public comment, please press star 9 on your phone to take your place in the queue.
Hello, Chair and members of this committee. My name is Catherine Nielsen. I'm the Executive Director of the Nevada Governor's Council on Developmental Disabilities. We just want to remind you that individuals with intellectual and developmental disabilities are at an increased risk of co-occurring disabilities with mental health conditions. And these mental health conditions include, but are not limited to, major depressive disorder, bipolar disorder, anxieties, among other things. And people with IDD and mental health conditions often experience symptoms that lead to services being provided within the mental health service system framework. And most mental health professionals do not receive sufficient training on the needs of this diverse population. We recognize the challenges that policymakers and administrators face in addressing the current needs of the mental health care in Nevada. And currently available treatment options in Nevada are not sufficient enough to serve the current needs of this community. Increased access to mental health services is necessary to meet the needs of those with IDD in our state and other mental health conditions. And we're very excited to see this on the agenda today. Thank you so much.
Hello, good morning. I'm sorry, I am traveling on the bus, so it's a bit noisy. This is Dora Martinez, Nevada Council of the Blind Legislative Liaison. Good morning to you, Chair and members of the hardworking committee. I just want to ditto Executive Director Nielsen's point and many others of the PEP people. I also want to bring it to your attention, Chair and members of this committee and LCB and whoever is putting on the agenda on your website to please make it accessible. It was really hard for me to locate the number and even to read the packet that is being discussed today. We need to do better. This is sort of going to that saying, nothing about us without us. I am a blind activist, and I want to be involved, and I want to bring good points to you all because I am a person with disability and I live the life, and I think that my point would be valuable to you all, considering that I deal with disability and other things. So it would be really helpful if the agenda and the packet is accessible to us all, so we can access it just like the counterpart. This is America and everything is great here, and I want to be informed constituents. So thank you for your time. I appreciate all of you, and let's do better. Take care. Bye-bye.
Chair, there are no more callers wishing to participate.
Thank you so much. Anyone else for public comment? It looks like we have one more. The microphone, please.
Hey.
There you go.
Hello, my name is Ashley Noel Pruitt, ASHLEY PRUITT. I am a student over at UNLV's Doctorate of Public Policy program, and my focus area is children's mental health navigation. I'm also part of the coalition here today. So I would like to just have a reminder for you guys to remember that children with mental health disabilities and needs become adults with mental health disabilities and needs. The decisions that we make today are going to impact us in the future, so I strongly urge the committee to continue to set us up for future success. Consider The key points that were offered here today by the coalition, they have been thoughtfully researched and whittled down to areas that we really believe can make an effort and make a difference for us here in Nevada. And I just want to say thank you again for having us here and allowing our thoughts to be heard. Thank you.
Thank you so much. I'll go ahead and close public comment at this time, seeing that there are normal folks looking to participate. We're going to go on to agenda item 3, which is the approval of minutes for the meeting on March 11th, 2024. Committee members, are there any questions regarding the minutes? Seeing none, I'll go ahead and entertain a motion to approve the minutes by the committee meeting on February 16th, 2024.
So moved.
We have a motion from Assemblywoman Brown-May. Do we have a second? A second from Assemblyman Orenlicker. Is there any discussion? All those in favor, please say aye. Aye. Any nays? Motion carries, and it is passed. Next, we will go ahead and go on to agenda item 4, which is a consideration of regulations proposed or adopted by certain licensing boards pursuant to NRS 439B. For this, like always, we always have Mr. Robbins, who will go ahead and give us an overview, and then we'll go to questions and discussion.
Eric Robbins, LCB Legal, for the record. So we have 4 regulations for the committee's consideration today. RO26-24 of the Aging and Disability Services Division, RO0224 and RO8424 of the Board of Psychological Examiners, and RO5324 of the State Board of Pharmacy. So there are representatives from the Aging and Disability Services Division and the State Board of Pharmacy here to answer any questions about those regulations. If you have questions concerning the regulations of the Board of Psychological Examiners, unfortunately, they were not able to have someone be available today, but because they had their adoption hearing on Friday, I'm not sure if they were actually adopted or not, but because they are on a quick schedule with these, we decided that it was best to go ahead and have the committee hearing, as the input from the committee isn't really very useful if the regulations have already been adopted and approved by the Legislative Commission. So if you do have questions regarding those regulations or comments, please note them on the record. And then I have provided the members of the committee with the contact information for the Executive Director of the Board of Psychological Examiners, so you can provide your feedback to them that way. All right, that is all.
Thank you so much, Mr. Robbins. Committee members, do we have any questions from any of them that we would like to pull out? It sounds like we have questions on the first one, LCB file R026-24 of the Aging and Disability Services Division. Any other ones that we would like to pull out?
Mr. Chair, just a question for Mr. Robbins.
Please proceed.
So thank you very much, Eric, for sending that email to all of us. I believe it was yesterday, very early in the morning. But again, my concern is that some of these regulations do go to the boards to get adopted and passed prior to us actually having an opportunity to look at them and ask questions. And so I guess I would just hope that we try to get these in as timely manner as possible in case we did have, although I'm not pulling anything today. I do appreciate the update on what the status is on these regulations. So thank you.
Thank you so much. Any other ones that we would like to pull out? And as he mentioned, the Board of Psychological Examiners is not here today, so if they have any questions, it would be out just for the record. Let's go ahead and start with LCB file R026-24. Assemblywoman Brownman, please begin.
Thank you, Chair. I have 3 quick questions relative to this regulation. The first is a reference to or billing date, the date of payment for. So on page 28 of the draft proposed regulation, the language changes from at least 6 years after termination of to the date of payment for the provision of the supported living arrangement service. That notation is made again for jobs and day training services on page 44. I'm curious to know if it's actually date of payment from the state of Nevada, or is it date that the provider organization submits payment to request for reimbursement of that services? There are times that the state has 90 days to make payment to the provider organization, so I'm curious to know what is actually the date.
Thank you. And I believe we have a representative virtually, so if you want to go ahead and respond.
Good morning. This is Jessica Adams, and I'm the Deputy Administrator over Aging and Disability Services, Developmental Services Programs. Thank you for that question regarding the date of payment. It is from the date that the provider receives payment. We made this change to the regulation at the provider's request. Previously, when we said 6 years after the termination of services, providers felt that they had to keep every single record that they ever carried on the person, whether even if they served them for 20 years, right? So they asked for us to change it to the date of payment of service so that they would know that they could kind of get rid of records and still maintain the 6 years that they had to have for the possible Medicaid look back.
Thank you for that clarification. It's really good to see you here today. I would also like to offer my congratulations and really good work for the provisions that are put in with regard to medication administration. Really good work done there. My second question is on number 15. It's page 47 of our documentation, where it says the provider of jobs and day training services has failed to accept a written service authorization or delivery. So it's saying that the regulation can be eliminated. The certification can be eliminated if a provider of jobs and day training has not delivered service within 12 months after the issuance of a provisional certificate. Is that upon initial approval? Is that a new cert? Like, there just seemed to be a little bit of confusion around that piece.
Jessica Adams, again, for the record. That is for providers that we have. We have a very small number of providers who will have gone through the entire certification process, receive their provisional certificate, and then never take a person. They never provide a single service over the course of 12 months. And so those would be the providers that we would then be revoking that certification because they don't seem to actually want to work with us.
Thank you for that clarification. And my last question is probably not going to need a response today, really just for something for us to think about. It says that we need 3 or more letters of professional reference on page 18 when looking to first apply to become a provider. As we have conversations throughout the state with regard to licensure, how do we help people get into service more quickly? It seems like this keeps popping up, 3 or more letters of professional reference. Once the organization's already gone through fingerprinting and background checks and other certifications to licensure, I'm curious to know what really is the implication of 3 reference letters, and are we slowing the process down?
So Jessica Adams, for the record, I can say that when it comes to applicants, we have not seen this. These would be brand new applicants for a provider agency. We have made quite a lot of changes to the certification standards when it comes to the individual staff, because they used to also need like reference checks. And so we have made some changes to that so that we don't hold anything up there. I am not aware of any issue with provider agencies having a difficulty providing us with references.
Thank you for that clarification. And again, I want to congratulate you on the really good efforts for this regulation in particular. I know it's a lot of work. Thank you, Chair, for the time.
Thank you so much. Any other questions? Any other questions on any other regulations?
Wait,
the agenda.
Mr. Chair,
Senator
sorry.
Reyes.
So on that same regulation, you just got me curious at this point. You actually take away a license after 1 year if they haven't seen a patient without any due cause other than the fact that they haven't seen a patient or a client?
Jessica Adams, for the record, it would not be without contact. Typically, the way that our services work is once they are approved and they're a certified vendor, we have things called vendor calls. And so anybody who would need services, those vendor calls go out to everybody who is eligible. Every provider who is eligible. So that provider likely would have gotten many referrals over the course of that year and have not taken a single one of them. And we also would have been having conversations with them saying, hey, what's going on? This is a very rare circumstance. I think it's happened like 2 or 3 times. It's not an easy process to go through our certification. They're working with a very vulnerable population of people. So we make sure that they're able to, do that. I think it's, like I said, maybe happened maybe 3 times, and we've had somebody go through all of that and then decide to just not serve us.
And this may be more of a question for staff. Are there any professional licensing boards that take away a license if they don't have a client or a patient? I mean, I just think after all the effort to take it away in a year, if they haven't accepted anybody, is just, I'm not so sure that's a good policy at all. And I was just curious to see if that's standard practice in other licensing board, especially like you just said, after all the effort folks go to get that license.
Eric Robbins, LCB Legal, for the record. I am not really aware of any other professional or of any professional licensing boards that that do that. So, but I can conduct a more thorough search and follow up.
Yes, I'd appreciate that. Thank you.
Thank you so much. Any other questions on any other regulations? Senator Titus, are we good?
No, thank you.
Okay. We'll go ahead and close this agenda item. So item 4 is now closed, and we'll move on to agenda item 5, overview of Nevada's Medicaid Children's Behavioral Health Services transformation. At this time, we will go ahead and welcome Ms. Stacy Weeks, who is the Administrator of the Division of Healthcare Financing and Policy. So welcome back, and please begin when you are ready.
Good morning, Mr. Chair. Stacy Weeks, for the record, Division of Healthcare Financing and Policy. I'm going to share my screen, and hopefully you guys can see it there. So let me try this real quick. Go. Share. All right. Okay, I think it's working. Otherwise, chime in if it's not, Mr. Chair. And I'm going to go ahead and dive in. Good morning. Thank you for having us this morning. It was very helpful, too, to hear from everyone's comments beforehand. I think a lot of folks come to the table. As you all know, there's a lot of issues in our system when it comes to providing services for children with behavioral health challenges. Today, we're going to go through a little bit of background on the data about what we know about the children we serve in Medicaid, some of the reforms that we are undergoing right now because of the Department of Justice findings that we were out of compliance with the Americans with Disabilities Act for this population. So I wanted to walk folks through that, as well as some of the delivery system reforms that we're going to be taking over, or at least taking on over the next 2 years. It's going to take us time, I think, to reform the system, but that is something we know we need to tackle. And then at the end, I wanted to kind of remind folks about some of the funding that we have for this work, thanks to lawmakers and the hospitals. For the private hospital tax, we do have funding for children's behavioral health, so that is also a win, but the funding is not unlimited, so we'll talk a little bit about that. And then I just want to walk you guys through our timeline and then open it up for questions. I do have a list at the end as gaps and opportunities for members' consideration, and happy to dive into any of those, as well as provide follow-up information if members are interested. So just a reminder, in October of 2022, the U.S. Department of Justice found that Nevada was out of compliance with the Americans with Disabilities Act for children with behavioral health disorders. And specifically, it's because we do not provide adequate community services in our programs from a public perspective. And when we look at the system, we really rely on these segregated institutional settings, like hospital inpatient services, residential treatment facilities. And sometimes this is the only option that families have for children with serious behavioral health challenges. And the DOJ's findings are that we need to really develop a community-based service, home and community-based service system for these children. We currently are still in confidential negotiations. I will say, I know it feels like a long time, but I was just talking to some other states at this conference that I'm at, and they've been in confidential negotiations with the DOJ as well for years. So it's a process, as it always is with attorneys, I know, but we are still in those negotiations. But I think what we all know here today is that the need is too great for us to wait until this is done. And so we have the funding, thank you. And so we really want to move forward on these reforms. So we've taken some things to IFC already to get going to develop these services. And we'll talk a little bit about that here in a minute. Just a snapshot of the children in Medicaid with serious emotional disorder, or what we consider, because when children are younger, Children are not diagnosed with serious mental illness like an adult would be. And a lot of that has to do with stigma, but also, just recognizing children grow and hopefully, maybe they don't end up with SMI. Maybe we can get them early enough to help treat the illness or the issue. But when we look at the population that we currently serve and the children that we serve, we think about 1 in 6 have a serious emotional disorder. And that's a lot of children when you think about nearly half of our population as children that we cover. And when you look at the pie here, 6% of the children that have SED or have serious emotional disorders or challenges with behavioral health, we think about most of them just have the behavioral health challenge, but there are 6% that we estimate that also have a substance use problem and have been diagnosed with some sort of substance use related disorder or challenge and condition. And then another 6% we estimate have what we consider an intellectual developmental disability. This could be a child with fetal alcohol syndrome or a child with autism. Typically they exhibit conditions in both categories of a developmental disorder as well as a behavioral health condition. And so the population that we're trying to look at under the DOJ settlement agreement includes all children. So we cannot pull these populations out because they have a dual diagnosis. So our new system needs to address these issues, but it also cannot use a wait list to really cap that group. We have to look at the entire population and not limit services. Just wanted to give you guys some more data on this population. When we look at the population, a majority, no surprise, live in Clark County. Most of our state lives in Clark County, but don't forget the north, right? As you can see, though, we look in Washoe County, when you compare that to the rural areas, it's a little bit more than our rural areas, and a huge, significant number of children with behavioral health challenges that need services live in Clark County. 1 in 12 with SED, like I said, that are in the Medicaid that are in Medicaid with SED are in our state's foster care system as well. SED, the challenges around behavioral health affect females and male children mostly equally. We looked at by gender. We also looked at the most common reason for out-of-state care for this population, and that's residential treatment. No surprise, because we don't have any community-based services or anything that families can bring into their home that we pay for to help families meet the needs of their children. So a lot of children are being placed in residential treatment centers, and when there are no placements here, we are sending them out of state. The cost annually for these out-of-state services is roughly $5.8 million, with the federal share covering the remaining costs. So it's definitely bigger than that. That is the state share is $5.8 million, roughly. About 60% of these kids that are being sent out of state are in our foster care system, with the majority of these 60% being between the ages of 13 and 20. So just really challenging to find a place for them in the state, and then also a center that will take some of these challenges. Some of these kids present with some significant behavioral health challenges and conditions that are hard to meet. And so we end up looking out of state. And looking at our work with the DOJ and what can we do better from a payer system and building a business system, right? Business model to support behavioral health in a community and home. And then what can we do with our partners, as we really wanted to set a vision and values around this work. And the vision at the Department of Health and Human Services for children is really to have access to behavioral health services, that these children have this access when they need it to live and thrive with their families and in their communities. They should not have to go to residential treatment unless they absolutely need to for a variety, some kids will still need those services, but we really want to get to children early and upstream to try to prevent that. And the values are that we build this in a child-centered, family-focused way. We often struggle, I think, to get family voices at the table, and that's something that we will be doing in the next few months or years as we build this model, is make sure that we're doing it with not just the provider community, but also families at the table, and looking at it to be community-based and it's accountable. Something that I think all states struggle with is who's accountable, right, for this work, and who do we hold accountable for these services, and making sure children get these services in their home and community, and then making sure that we do that in a coordinated way. Something that we are working hard with our Division of Child and Family Services and other sister divisions, is to make sure that as we build this, that we are working together and that we do that in a coordinated way. Just a recap from last time. I know I showed this visual before, so I apologize, but I wanted to go ahead and give this as a quick reminder that when we think of the continuum, this is the continuum for behavioral health care that we want to make sure that we're building and growing. Right now, we are primarily, like I mentioned, relying on that right side of the slide, that high intensity residential inpatient treatment, right? When children or even adults have had, just cannot, right? They're not stable in the community. They need those intense services. That is where we're at with this population. And we really want to be getting up earlier, screening kids earlier, assessing them earlier, identifying them earlier so they get services that they need and in their community, right? In that bubble number 2, if they need them. And so they're not cycling in and out of our crisis high intensity level of services. So again, we're really building that second bubble there that we really lack in this state. And I would just mention that those are more cost effective as well. So when we think about the budget and like from a state budgeting perspective, the cost-effective services really are in those first 2 bubbles, as well as the third, right? Crisis mobile response is preventing, in some ways, stabilizing people, hopefully in their communities. Some people do not need to go inpatient. And so really trying to get on that left side of the continuum. This is a visual that we shared with the IFC in April when we went to ask for new services to really develop a system for children in Medicaid. And when we look at today, some of these services are covered, but the way we cover them is inadequate. And sometimes it's only primarily for our foster care families. And what we want to do is open up that box in the middle, that home and community-based services for children with serious emotional disorders and foster care children in a way that supports any family that falls in that bucket. And any family with a child who may have SED as well as an intellectual developmental disability, they have the supports they need in their community regardless. And so that is what we're trying to build. And so some of the new services we'll talk about here in a second on the next slide so you can see that better. But on the left here, when a child is entering school or going to a primary care clinic or anytime entering the system in some way, either state or county or the healthcare system, we're really going to be looking at trying to mandate or incentivize comprehensive screenings and assessments of all children who are entering some sort of setting that we can do this work. Like the school system is a great place that we know we can do better. As our hope is we'll screen, assess, identify, and then, oops, did I cut out for a second? Let's see. Can you guys hear me okay, Mr. Chair?
You're good. Please proceed.
Okay, yes, it's great. It keeps telling me Zoom is going out and I apologize. I think I'm back, Mr. Chair, sorry.
You're good. Please proceed.
Okay, technology, it haunts me. Okay, I'm gonna go back to the screen. All right, share. Okay, can everybody see that? Okay, good. All right, let's keep fingers crossed. So when someone's coming in the system and they're screened and assessed for at risk, we're looking at also creating a bucket for eligibility. So if a child is at risk of serious emotional disorder, they would have access to some of these services to help prevent being having the designation of a serious emotional disorder. So we're looking at that as also an eligibility criteria. We got feedback from stakeholders on that. But when they are identified as needing services, they would get what most people call wraparound facilitation, where you get a child and family team, and someone who's going to actually manage that child's case. It's intensive case management and care management, essentially, for that child and family. And then additionally, they would have family and youth peer supports available, individual and family therapy in their community or in their home, looking at telehealth as well for some of our rural areas where we're challenged with provider access, psychosocial rehab services, and planned and emergency respite care. Planned and emergency respite care and wraparound are our 2 big new services. Planned and emergency respite care is not cheap, but we have found that it is one of the most needed services for families, and one of the ways that families may keep their child longer in their home and not feel the need that they have to put them into placement or give up custody of their child, so the child can access care. On the side here are services that we already cover, except for employment supports. but just making sure that families know that they can access these services. What we find is a lot of folks, because many of these children are in our fee-for-service system, they lack some sort of management and they lack knowing that they have access to these services. And so making sure that if a child is eligible, that they get transportation, they have psychiatric care, that we've got medication management, mobile crisis and stabilization service, they know how to access them, day treatment, intensive outpatient services where available, same with partial hospitalization. And the new one down there is youth employment supports, and I'll talk a little bit more about that shortly. And on the right here, we, not to forget that we do have a residential treatment system, right? Like we don't want to just reform the home and community-based service system. We want to look at when we do have children that need residential and inpatient care, they're getting quality care and that we are paying for those services adequately. So what we're going to be doing is reforming payments as of January 1. We will be doing a quality incentive payment for residential treatment centers that show good outcomes. So shorter stays, right? That the children aren't staying there forever, and that they have successful discharges. That means that they are successfully transitioning into their community and they are doing well in their community. And so we're looking at ways to measure that now and then setting a baseline year for next year. And then those bonus payments would be about $100 a day per child that we could pay the facility. The other bonus payments that we're looking at adding into our residential treatment center program is bonus payments for centers that are accepting children with complex needs or young children. And then we'll talk a little bit more too about some of this, but a new step down group home model for youth with shorter stays. We're also looking at creating a dashboard with our Office of Analytics. We want to monitor children and track their outcomes in a better way and making sure that we are not losing children, and where there's gaps, we're going to be looking at trying to fill those gaps. It's definitely a multi-year process. It's going to take some time for us to build that. That is why we went to April IFC to ask to get some of the funding that we had available to start this work and building these services. Real quick, this is a table. It's kind of what we talked about on the other slide, but I wanted you guys to kind of see it from, and depending on what kind of visual person you are, this might help you look at the buckets of the continuum by service. And so when you think of wraparound, it would really be available for a family, regardless of where that child is in our continuum, that child and family team is there to support them and manage their care. And provide that intensive care coordination as well. Peer supports would be available. We also, the light blue there are what we would consider new covered service, or we're increasing rates. So for wraparound, that's new. For peer supports and services, we will be increasing the rates for these services and adding youth and family peer support starting January 1 of 2025. Residential treatment, we're going to be increasing the rates to $800 flat rate. No longer will children in certain areas of the state, where depending on where they're at, the rates are lower or higher, right? And so we want some equity across the system for kids. And so we're going to be increasing that rate to $800 a day, which we think is a fair market rate, and then adding those bonus payments depending on quality and then complex needs. We're also adding respite care as a new benefit, planned in emergency. The QRTP, this is a model that came out of the Family Services Supports Act. We're looking at a similar model, group home model for youth, maybe foster care, but maybe not foster care. We're looking at other states that have added this to their Medicaid program as a way to support youth as a step down to a residential setting. So they're not quite ready to go back at home, or maybe they don't have a home to go to yet. And so this is sort of a step down model where they're more in the community and they're actually in a community setting, but they still have supports in that group home model to support the child or the youth. Intensive targeted case management services, we'll be looking at different ways to provide those services, and we'll talk about that in a minute. For the delivery reform, intensive in-home supports, we're expanding that to not just foster care kids, but also all families and children who need these services with serious emotional disorders. This also is a bucket where we're increasing rates for these services that fall under that category. We're also increasing inpatient hospital psych rates to give them parity with acute care when someone comes into acute setting, acute hospital, and needs psychiatric services, just creating parity and supporting our psychiatric hospital system, which I think you all know is struggling statewide. Psychosocial rehab services, we are increasing the rates there, as well as individual family therapy services. And on those rates, we're also adding a bonus payment for services provided in rural communities, even through telehealth. So we're just trying to really encourage people to serve rural areas of the state and not forget children in those communities. And then the blue buckets we currently have in place, I would just note that we are looking at ways and probably going to be trying to increase rates for other areas in these buckets based on our quadrennial rate review, which I mentioned to you guys last time, showed some gaps for some of these provider types. So we're looking at ways and whether or not we have sufficient funding now to do some bare minimum rate increases in some of these areas around access. And then the last one there, 988, we're looking at ways to leverage Medicaid funding to support 988 and referrals coming out of that system. Let's see. I've mentioned a lot about this. I'm sorry, I was kind of duplicative here, but I'm just reminding we have a new flat rate of $800 per day for residential treatment centers starting January 1 of 2025, and then those add-on payments that we are hoping will incentivize quality, but also accept some of our children where we have a hard time now that we have to place a lot of children out of state, right? They have the complex, challenging needs, or our younger children. We don't really have many places for children under the age of 9 or even 12 for placement. And then, like I mentioned, the quality bonus, making sure that our residential treatment centers, that we are driving quality in how we pay them and rewarding those that help children transition back to their families or in their communities. Other Medicaid investments that we got approved at IFC, I already mentioned the Qualified Residential Treatment Program as well. The other one here we have not brought to IFC, but is something we are already doing, is looking, we will be removing the requirement that counties have to pay the state share. This should be a statewide program. School health services are covered by Medicaid, so we are no longer requiring that the county pay the state share. We are picking up the state share cost. It is affordable for us. We need to do it, and this will hopefully help improve access to services for children that are Medicaid eligible in the school system. But we're looking at that as a way to really start to increase screening and so we'll be working with Department of Education and other partners on ways to increase screening for behavioral health conditions at the school setting, as well as trying to help children in the schools get services for behavioral health needs. And I already mentioned some of these, the rate increases for the across here. And like I mentioned, the rate parity for psych. We're also removing any barriers around prior authorization. We've had some barriers for crisis intervention, so we're removing prior authorization in that way. I would just note on this piece, we heard a lot of public comment earlier about prior authorization, and we hear that quite often. It is a struggle on our end. You know, we can't, if we just paid everything, we often find that there is fraud and that we have to be mindful of fraud, but we also be mindful that piece is important, but we will also want to make sure that people are getting services. And so one thing that we are planning to do is revisit prior authorization and how it's used and look at data around how often it's already being approved. And so, for example, if a service is 90% of the time being approved, why do we have the prior authorization, right? Like, what is it there for and why? And are there other ways that we can be preventing fraud? So we are looking at that, not just for behavioral health, but we're looking at that more broadly for our entire program. But I would just note that these are tools that we have to help prevent fraud. And like I mentioned last time, unfortunately, behavioral health is the largest area of fraud for the Medicaid program when it comes to provider fraud. And that's very unfortunate and disappointing for us because this is an area where we have the most need right now. So we are looking at other ways, though, to address fraud without always using prior authorization. Delivery system needs. So the other piece that we're bringing to June IFC later this week is a proposal for staffing and funding for a vendor to support delivery system reform for children. Today, children in foster care, many children with serious behavioral health conditions are served through our fee-for-service system. And what other states have found, and I think it's true in Nevada, that our fee-for-service system is definitely outdated, and it many times can lead to fragmented care because there's really no clear line of accountability for coordinating care, managing services, developing an adequate network, or even ensuring quality services. We don't have the capacity to do it. it's not required at the federal level. And so we're just not doing the same level of service that we are in the managed care system. What other states have found for this specialized population is that looking at a specialized managed care plan, so one entity being responsible for filling that void at the state and local levels. It's a lot for both the state and the county, even the counties that do some of the case management for these children, to really have all the expertise and all the services they need to provide these services. So we're looking at ways to bring in a specialized managed care plan in the next 2 years to assist the state with better managing this program, overseeing quality, tracking outcomes, supplementing county support where we need it, and just really doing what we know other states are doing, and it's at least doing more than we can today with what we have. Ohio, Arizona, and Washington are 3 states that we are looking at as models in this area, and they've found that they can bolster resources and support kids, including care coordination, case management for children in foster care. And like I mentioned, we're going to be adding children with behavioral health needs in that bucket so we can make sure they have access to their home and community-based service program. So this is a visual of what we're trying to build for this new specialized program for this population. So on the left side here is our what we would consider best practice integrated benefit. So it's treating behavioral health, not a separate program. It's trying to make sure it's integrated. The home and community-based service model, like I mentioned earlier, that behavioral health care system is part of healthcare, right? And so making sure it's an integrated benefit so families know that they have medical services too. They have behavioral health services. They have access to all of the services we talked about earlier. They have transportation. I heard the other day that some of our foster care families didn't even know that they have access to transportation, which is shocking, right? But again, it's that fee-for-service model where we do not have a managed care entity making sure that they're being reminded that they have these services to help get the child to the care and the treatment. And that intensive care case and care management bucket is a piece that is part of this integrated model. And then on the side here is all of the types of requirements that in managed care we have to have. And then there's some of them are nice flexibilities that we also get through managed care that we can't get through fee-for-service. So managed care federal law requires certain network adequacy standards and testing before we go live. And if we don't have that access, the CMS will not sign off on it. So there is a lot of work that has to go into building that network. We have an external quality vendor that works on that and assesses the network, not us. And so it's really bringing that expertise to the table, but also having that independent look at our network. One nice thing about managed care is that the profits, right? And so these entities, when they profit or they come to this table, we can often ask them to use, if we can't cover it through Medicaid and it benefits the program and lowers the cost, they will often do what's called a value added service. And so employment and housing supports are areas we know we can add as value added services. And so we're going to be working hard to get a plan in that can provide those as services to families as value add. So it does not affect the Medicaid program or budget, but it is a value add to this program. The other piece is that states that have these specialized managed care plans, they all have collaboration agreements that they do specifically with schools, child welfare systems, counties, states, and all the partners that are involved with these children, including judges and courts, to ensure that there is that coordination that's going on and that roles and responsibilities, which we all know is really important to this work, are very clear. And we will play a big part in that, in making sure we want to make sure we have folks from all areas at the table when we're developing our contract and our model contract for this plan. So what we put together, everyone understands what they can get from this and how they can hold that managed care entity accountable. The other piece that we hope we will provide through this is a 24-hour family nurse support line for families. We also are looking at quality incentives for providers and performance monitoring, which will be nice to have like we have in our managed care program, but in a way where we can really track provider outcomes in a better way and really measure them to national HEDIS metrics and other standards where we can look to see how are we doing nationally. And then community reinvestment and workforce development. The other piece that Nevada started doing on its own at the last contract period, I think was one of the first states to do this, was to ask their plans to reinvest their profit. So we have for-profit managed care entities. And so unlike nonprofits that invest profits, for-profits don't have to. And so our contracts include a provision requiring them to invest at least 3% of their profits back into their communities we would be asking this plan to invest a percentage of its profits back into the communities and the services that these children and families need, and possibly even workforce development. That is an area we're looking at, since we know that is a huge need in our state. To make any of this work, we need the workforce. So what can we have those investments back into services, but not just social services, but also that workforce piece. So those are some of the things that we are looking at. Just as a reminder, last year, Senate Bill 435, Senator Titus's legislation, allows Nevada Medicaid to use up to 15% of the revenue from the private hospital tax for administrative costs for the tax, but also to improve access to Medicaid behavioral health care services. This funding, it's not unlimited, but it is sufficient at this time to help us build this new system as well as build out these services. We went to IFC, like I mentioned, in April, and everything was approved. I'm very, very pleased. So thank you to those of you who sat on IFC. And then we'll be coming back later this week to talk about the managed care system and the vendor and staffing support we need within Medicaid to build out this new program and to really make sure we are monitoring services for children in our state. The estimated timeline is here. And so on the left side, we have what we are currently in the process right now of developing new benefits. So once we get through June IFC, if all goes well, fingers crossed, we will be working hard to get everything submitted to CMS, working with stakeholders before we submit, though, to make sure the benefits align with feedback. And then as well, we'll be looking for a vendor to help us start drafting a model contract for this new specialized managed care plan. We are looking at effective date January 1, 2025 for all the rate increases and rate changes that I already mentioned, possibly looking at adding more. We are costing that out at this time. So for like day treatment and other services we'll be looking at. And then our goal for our HCBS package approval, we're hopeful July 1, 2025, but I hesitate because I never know what CMS's backlog is, because I know we have one, but I know that they have a greater one. So hoping that we can choose the right authority that gets us to the shortest line. Looking at a 1959 state plan because it seems to be quicker for us to get. So we're looking at that as an option at this time. And then looking to post and do a procurement January 1, 2026 for the new specialized plan. And in the meantime, that arrow at the bottom there is that the intensive stakeholder engagement. We're going to have several forums for public. Two of them will be advisory committees. We'll be looking and putting out an application process, but we want to really make sure we have families at the table. But then when it comes to the procurement, in the new specialized managed care plan, we want to make sure we have our counties, our court systems, everyone that touches a child in the system at that table to make sure that the system we put together supports their needs and is actually improving and moving us forward, because otherwise this would not be worth all this work, right? So it needs to make sure it's moving us forward. And then we're hopeful we'll have everything set up by January 1, 2027. Again, the benefits will come online before then, so families can access them through the traditional fee-for-service system. But like I mentioned, we believe that the specialized managed care plan really will help boost that system in a way that we haven't been able to do today. And I think that might be, and then my last slide, I think, is gaps and opportunities. So some of these are familiar from last time, an area that, that we do think a gap in the state is this a bundled rate and a bundled package for a sort of community treatment model. It's an evidence-based model that we think could help with services with young adults and youth, as well as adults in the community for behavioral health. School behavioral health services, like I mentioned, there's one thing other states are looking at. I know other schools in the state have done this already, looking to get a billing vendor to help them bill, because the capacity to bill for Medicaid, as you heard earlier, it requires someone like a billing specialist and to understand all the codes and all the requirements. And, as much as we want to streamline and improve it, insurance is insurance, and it's hard to make it not just completely, there is going to be burden regardless. And we are looking at ways to streamline our school health services and looking at one manual. And so when schools want to bill, it's not as confusing. They don't have to go to 3 or 4 different chapters of our policy to figure out how to bill. So we're looking at doing that now, but just looking through opportunities to fund some sort of centralized school billing service for schools, as well as electronic health record system for them. And other piece here is we lack sufficiently skilled, licensed, certified workforce, right, for a lot of these services. And so, oops, let me go back. Sorry about that. And looking at ways to build that workforce. And so we've been talking a little bit to our university partners, but just, that is a struggle of the state. A lot of states struggle in this area, but I think Nevada is extremely struggling with workforce at this time. And services, what types of services and system can we put together that meets children, the needs of children that have dual diagnoses, especially the intellectual developmental disabled and serious emotional disorder. So those two together, right now there's sort of a two bifurcated system. And how do we make sure children can get the services they need regardless? And then looking at rate gaps for different outpatient services and ways that we can increase those rates. I think you've heard that over and over again. It seems to be a theme. And I think, we would agree that historically we have underfunded our system in Nevada for a variety of reasons. And it's good and bad, right? We have to budget, but I do think that there is something to say here about increasing rates for our provider system. And then looking at gaps in primary care and pediatrics. This is where we can really start helping families earlier before a child has really hit the point where they have to go into the residential treatment center. And like the primary care workforce in the state is lacking. And what can we do to really increase that access? Other states are looking at that as well, especially in the pediatric side. Rural access challenges, like I mentioned, we're looking at creative payment strategies to help with this need and telehealth, but we recognize there's also a lack of trust sometimes in our rural areas. And so how do we also create a system with this new specialized managed care entity where we can build trust and ensure that families in those areas access the services they have available to them, and we remove any stigma associated with that. And then I think that's it. So I will stand for questions and I'll stop sharing my screen, Mr. Chair.
Thank you so much, Ms. Weeks. Any questions from committee members? Assemblywoman Brown-May.
Thank you, Mr. Chair. Thank you, Administrator Weeks. Great presentation. I appreciate all of your hard work on this and supporting our children. I have two questions. My first would be relative to slide number 4. When you talk about the snapshot of children in Medicaid with social emotional disturbance or disorder, substance use disorder, IDD, right? We're talking about dual diagnosis populations, but I'm curious to know, this has come up in the past, providers, when they see children, offer a diagnosis in order to bill for services. And are we diagnosing children in the beginning of a support service that may not be necessary, which will follow them throughout the rest of their lives? Is there any incentive to add perhaps a family wellness check in the billing codes so that we can allow children in distress or in crisis an opportunity to seek services without having a lifelong diagnosis follow them?
Mr. Chair, committee member Stacy Weeks for the record. That's a really good question, and I really appreciate it because it's come up a couple of times in our stakeholder meetings. And I will tell you that is one of the reasons we're trying to create sort of this at-risk category, so we don't always have to have this diagnosis, that we can get kids who have certain symptoms or have had circumstances like a mobile crisis visit or other challenges where we can, juvenile justice, right, or anything where they've had some interaction in different ways or had required certain services, that we can say, okay, they're at risk of serious emotional disorder. So really looking at the community for advice on that, because we don't want to, like you said, stigmatize children and families to also avoid the services because they're afraid of some sort of stigma that comes along with the designation of serious emotional disorder. I think that's why we have that designation, right? People didn't want serious mental illness, but even SED on its own has stigma. So how can we create an eligibility category that is really for at-risk children? So that's the goal of that, but I think we need to flesh that out more, and would love your advice if you have any or comments that you want to share on that. We'll be working with, we have some expert vendors right now that we'll be working with, but we were looking for feedback on that.
Thank you. I look forward to following up with you offline relative to that. And then we have children who go through crisis situations like divorce, or serious mental illness or serious illness in a family member, right, which are times of crisis that we're able to help children navigate through. So I think care coordination in those situations wouldn't necessarily lead to a long-term diagnosis. So I'd like to work with you on that. And my second question is slide number 9. You talk about wraparound services, intensive care management, and care coordination. Do we have care coordinators now, while you're getting ready to make this wonderful transition to managed care, that will have care coordination as part of a managed care billing and service plan? Do we have care coordinators currently that are not state employees that we're able to contract and bill for care coordination services for?
Mr. Chair, committee member Stacy Weeks for the record. So we have state employees at our district offices at our division that do care coordination, but they're not specialized in behavioral health disorders. Part of our IFC request is to add 2 positions, even with the managed care entity, that really will assist us as well, because one of the things that we are lacking right now is that care coordination that's got the expertise we need to do this for children, and enough of them, right? So we are looking at adding that in the interim. That's one of the asks of the IFC, but to answer your question, no, we do not. And that's one of the reasons we feel like we need the specialized managed care plan that has the capacity and the resources to really support this population.
Thank you so much. Let's go to Senator Titus.
Thank you, Mr. Chair, and thank you, Administrator, for the information and the presentation and the lofty hopes for the future of what the state is trying to accomplish. And again, I do appreciate all the efforts. I want to kind of piggyback on what was just asked and for some clarification. On page 13, you mentioned that the fee-for-service delivery model can often lead to fragmented care, and I think that's what we just brought up. And my concern is we're there now. I mean, we have fee-for-service for these programs. You're looking at going for a provider network and do managed care. In the meantime, who's overseeing it? Where do we go? What happens? Because I'm hearing more and more about kind of kids that are lost in the system, concerns about who is out there monitoring these processes and these children, these agencies. What are we doing now?
Mr. Chair, committee member Stacy Weeks for the record. That's one of the reasons we didn't want to wait for the settlement agreement, because the longer we wait, all of this takes a long time to set up, even getting CMS approval for these services. And the longer we wait, it's years from now. And so the sad part of all of this is it's unfortunate. I think that's one of the reasons we're asking for those care coordinators to try to start doing more now. We're also looking at hopefully bringing in some clinicians. We did get a clinical position last IFC to help support Medicaid and our team and to work with DCFS and the counties. We do meet regularly with the counties, but I think once we get these positions, we need to create some sort of diversion, team to help children that are in the system, at least focusing on at least our foster care program for now. But we are at this point, that's one of the reasons we're here and trying to do this now, because I think people, the longer we wait, the harder, it takes so long to stand things up. And that's the unfortunate piece. So I apologize. I don't have a better answer, Senator.
Yeah, it's unfortunate, but I do understand that you are trying. On the same line of concern, page 8, I mean, I think this is excellent kind of forward thinking, but again, I'm kind of in the here and now of where these kids are, and I'm just wondering, available beds right now that we have our kids in, and just looking at numbers that perhaps you can get to this this committee on what available beds do we have in state, how many of our children are out of state, because this is going to start in January of 2025, but we have kids now that need these services. And so I'm just wondering about, yes, we're going to increase services, but do we have folks waiting that will take these kids when this increase happens? Those are my concerns. And so perhaps you can give us an update. I know you're not in the state right now, and I understand all of that, but perhaps you can get somebody that works with you to send us some of these numbers. What's the status of our kids right now? How many are going out of state? Do we have providers out there that are willing to step up if we increase the reimbursement rate? Because again, this looks great. I like the concept and the plan, but it's only a plan right now. And I'm hoping maybe it's like if you build it, they will come. I'm hoping that we have that kind of opportunity. So looking forward to that information. Thank you. Thank you, Mr. Chair.
Thank you so much. Let's go to Senator Nguyen.
Thank you, Ms. Weeks. I've had several people come up to me, advocates in the community, providers in the community, people working on the ground in the field, talking about some of the placement of these children. And they have been advocating for no eject, no reject policies at some of these facilities. Are there facilities that are open, that have beds, that have availability, and they are either ejecting these children with high needs or rejecting them from placement in those facilities because they don't meet their needs by 100%? And then we don't have placement for these children? Do you have any information or data on those kind of scenarios?
Mr. Chair, Stacy Weeks, for the record, I would have to follow up with you. Some of that lies with our Division of Public Health as well. So for licensing, they're probably tracking that more closely. I will say that what we end up doing, and that's one of the reasons we raise the rates, because we end up doing a letter of agreement, which is essentially a special arrangement where we will offer a higher rate. And sometimes we feel like we're being price gouged, I'll be frank with you. So we can place a child who has a lot of challenges, but for the most part, we do find a placement. It is just a challenge. And that's one of the reasons we need these care coordinators to help us do that better and to make sure they have the expertise and know all the providers as well. I mean, the challenge too we have is that some of these providers we end up, especially in out of state or even in our own state, we find out they're not good actors or there's not good conditions for these children. That's one of the reasons we're trying to build these home and community-based services, because we want to see fewer children having to be placed. But in the meantime, we are struggling, and that's one of the reasons these rate increases we're hoping will help, especially with our more complex children who we end up doing a higher rate regardless. So that's what we're doing now as a patchwork to get to this new system. But we can follow up on Senator Nguyen with more information.
Thank you. That would be wonderful. I know you kind of briefly said it, but I guess some of my concerns is kind of what you alluded to, that some of these facilities perhaps are not taking these children because they want additional fees or additional, price gouging-ish, I guess we can call it. What kind of metrics do we have, or what kind of accountability do we have to ensure that would the care managers be the ones to determine and follow up to make sure that these kids actually need this additional resources and that they're receiving them based on this increased pay?
Mr. Chair, committee member Stacy Weeks for the record. Yeah, so in addition to our care coordinators that we'd be getting that are specialized for these children, would also be working with the case managers in Clark and Washoe County. For rurals, they would be working with DCFS case managers. So we do fund case managers now that do some of that work. But that's one of the reasons we want to have the care coordination team do some of this too, so we have that feedback for Medicaid so we can better track it.
Thank you.
Thank you. Ms. Weeks, I just had a quick question. So my interpretation is, in terms of where the state needs to go, it sounds like, based on the public comment and some of the recurring themes nationally, that more needs to be focused on early intervention. And that's kind of the comments that you mentioned towards pediatric services and early intervention. So what are some of the gaps that you're seeing in terms of school-based systems of care? I know that in some states, for instance, in New Mexico, they require that every student in the state goes through a mental health screening, of course, with the permission of the parent. But, there's this kind of idea that we're screening all the kids to understand, are they going through emotions of sadness, depression, and so forth. And then we're providing them with the level of services so that they don't end up in a residential treatment facility or they're causing disruption in classrooms. So are there opportunities that you see in school-based systems of care? Is there more support that needs to be done through your office to be able to administer such a program, or is this more for the Department of Education? I would love your feedback on what we can do in that setting.
Mr. Chair, Stacy Weeks for the record. So we've been working very closely with Department of Education for like 6 months, it feels like, since we started really digging into the school health service side. I will say that I think there is more room there to do that work. And I think one of the things that we realized in our work is that we need to first help schools start billing too for these services. I think schools often, in Nevada, my understanding is the schools, it's a local control, right? So it's a very different model than some other states. And so I think it could be working with Department of Education to see what they need to institute sort of a blanket behavioral health screening policy. I do know that the university is very involved as well. They have a program that provides schools that want to participate with training, screening resources, tools, how to do evidence-based practice around behavioral health. I think more of that is what we need and more resources around that. It's called MTSS program. I feel bad because I'm trying to remember I think it's multi-tier system and services or services and systems, but it's UNR, but that kind of way of supporting schools, I think we need more of that. And from my perspective, but I also think from our perspective and what we could do in Medicaid is broaden the type of providers that we will reimburse for, because often what we are hearing is schools cannot afford to have a licensed psychologist, for example, on staff. And of course they can't, right? Like we all know what public school was like. I grew up in a small town. So what can we do to help them get those services? Is it telehealth that we can reimburse them for someone, or do we train their counselors, right, to do some of this work? So we're open to strategies and definitely looking at other states for best practices and models. But I think because of the workforce shortage, that is a big challenge for schools to provide a lot of these services.
Yeah, I would agree with that sentiment. I think the difficulty comes with it's kind of like the mission, right? At some point, the problems that the schools face could grow into such a capacity where our schools are not meant to be healthcare providers, right? They're meant to serve as educational institutions. And so what I've seen in other states is the model works, right? You're providing services of care, whether it's physical or mental, to students, but then if the problem gets too big, then how do we provide the school districts with the ability to at least provide some level of services in it? To me, it sounds like we need to create a system where there's either a pool of funding or these support services here to provide technical assistance so that the staff of the school, the educators, the families, and so forth are understanding what does it mean to have a mental health diagnosis, or maybe not even arrive to that, and that we're screening each child so that we don't end up down the line of having to fund residential treatment centers because they're at full capacity, right? I think that probably would make the most sense, but I don't think I have any other questions unless if there's anyone else. All right, we'll go ahead and close this agenda item, and we thank you so much for returning back. Let's go ahead and move on to our next agenda item. Our next agenda item is, give me 1 second so I can pull it up. Let's go to agenda item 6, which is a discussion of policy recommendations relating to children's behavioral health. With us, we have Councilman Knudsen. So welcome back, Councilman, and please begin when you're ready.
Well, thank you, Mr. Chair and members of the committee. I appreciate the opportunity to be here. I am going to talk for a second about my past experience, which maybe gives some credibility to why I sit here today. And then talks about some personal experiences, and then I'll go right into my recommendations based on a lot of the public comment you've heard already. If it's okay with you, Mr. Chair, I'm going to ask Alex from my team to hand you it's on cardstock, which means it's very informal. These are officially the recommendations that I think this committee should consider. So by way of background, I moved to Las Vegas in 2006. In my first couple of years here, I managed an after-school tutoring company, so I was with a lot of children. From kindergarten all the way through middle school kids. One of the things I learned early on is that kids that are struggling with some behavioral health challenges, if you've been around children, you're going to identify them pretty quickly. It takes about 5 minutes to walk into a room and identify those kids that may have some challenges that set them apart from the other children in the classroom. Following my time tutoring, I worked for the city of Las Vegas for 10 years in policy and strategy, and so I've been working in public policy landscape for quite a while now. I was also the CEO of the Boys and Girls Clubs of Southern Nevada. And one quick story I would just share with you to let you know the brevity or the complexity of this issue. There was one particular clubhouse where all the staff members in the Boys and Girls Clubs are between the ages of 18 and 25, and they're young and they're doing their very best to manage their own lives. But all of them in that clubhouse came to me and said, a lot of these kids are sexually abused. You can just sense it. You just know it. When you see the parents drop them off, they're doing drugs in the parking lot. They're dropping off their children. You know there's a level of abuse there that's not appropriate. And that led me to start working with the university at that time. This was a little while ago, 6 or 7 years ago, to talk to law enforcement, to talk to the county, at which time there was not a remedy. This is a lot of issues in our community. We have a lot of abuse going on. We have a lot of behavioral issues with students at now and then. And so the question is how do we inform parents that there's an issue? How do we inform parents that there's a challenge that if they were to address it early on, that behavioral health challenge that Ms. Weeks talked about doesn't become a serious emotional disorder later on. And so we started working with the staff members to train them on how do you talk to a parent to say, hey, let's pull you aside. Here's something that makes your kid very special, a little bit different, and we need to maybe address some of those issues early on. Fast forward, here I am, I'm a parent. So I have an 8-year-old and a 6-year-old. And this is what really brings me here today, because I hadn't really thought about children's mental health in a long time. I'd spent a lot of time thinking about crisis response. And from our last meeting, I think the state is doing a lot in crisis response. I think there's a lot of efforts going on there that we'll see improvements. That is not the same for children's mental health. That is a huge gap. And so I'll talk about it from personal experience. My son, my 8-year-old son, my 6-year-old daughter, both were adopted. And in school, I thought he was doing really well. And about 6 months into the last first grade school year, the dean of the school said, we're about ready to kick him out. And I said, ooh, do you know who I am? Don't kick him out. Don't do that. And it was because my son was acting in a way that wasn't productive. It wasn't what the other kids were doing. So he was climbing on the walls. He was acting out in class. And I didn't realize what that issue was. He also had a very nervous tic. He would eat strings. And so he'd be embarrassed 10 years from now if I told this story, but I used to bite my nails when I was a kid. And it was a serious issue. I used to bite my nails all the time. He ate strings. And so I really had a hard time with that. And we struggled with it for a couple of years. It started becoming an issue when teachers would point it out, when students would point it out. I would classify that as a behavioral health challenge. Now, if I didn't do anything about it, I think there's a real chance that later in his life he would have a serious emotional disorder, because it becomes a real big issue when you're in kindergarten, first grade, second grade, third grade, when that's all you hear is negative comments back about who you are. And so what I did was, based on my connections, my resources, I have double coverage insurance. I'm a public servant. I'm an elected official. There was nobody available to take a call, not a single person. This was based on 2 insurance companies, not Medicaid, two private insurance companies. So I did what I should do, is I reached out to my network. Many of them are here in this room today. And I said, what do I do with a kid who's struggling with a behavioral health issue? And as a family, it's kind of tearing us apart, because it's really stressful to see your kid struggling and you don't understand why. And so I got about 10 different recommendations. And of those 10, 8 never returned a call. 1 didn't take my insurance. 1 was cash pay. So we ended up with, and it was a wonderful relationship, and it still continues. But that is the issue at hand, and that's one thing I think that you all need to be very concerned about, is whatever system you set up as a state, if you don't have providers that are plugged into the system, cash pay doesn't work. It only works for people like me, and I have enormous access, enormous privilege, and I used it, and I only was able to get cash pay. Also, there's the conversation around identifying serious emotional disorders and that diagnosis. In order to get to someone to identify a diagnosis, you have to wait for a couple of years. That is the system that we have in Nevada. And so for all of those folks who have access, who have resources, who have privilege, it kind of works. I kind of pulled together the team of people to support my son, and he's doing amazing now. It was a random conversation with an occupational therapist that takes cash. To say he's eating strings because he has an oral fixation, just like me biting my nails, oral fixation. Give him a Starburst, he'll be fine. And over the course of 6 months, Starburst fixed the issue. So now he's happy, he's doing well in school, he has no behavioral health issues, and he's doing fine. That's the kind of system that I think we really need to focus on as a state. And so what I did when I was stressed out and I couldn't figure out how to deal with all that anxiety of having kids that weren't fitting in, and I wasn't fitting in, is I pulled together a team of mental health professionals, and I asked them, what is it that would make this state better? How can we fix what I consider to be non-existent, not even broken, just non-existent. A couple of things that I think shocked me is how many providers are cash pay. And I think that's something, again, I'm going to probably say it a few more times, is as a state, we really need to understand what would make a provider go to cash pay as opposed to take Medicaid or private insurance. If we can't understand why they're not plugging into the system, there's a whole segment of the population that you will never be talking about in this room today. The next thing that I thought was really shocking is there's no connective tissue, there's no connection between providers. And so a lot of these things will come out in these recommendations. But if you want to make a referral, if you're seeing a patient and you want to make a referral, I'm willing to bet all of them say we go to this Facebook page because they make referrals via Facebook because there's no connectivity. There's also very little professional development or training around children's mental health in the state. And so to get your continuing education credits, you're going to have to go online, you're going to have to go out of state. Those are some of the challenges that I think are really relatively easy to fix if we focus in on them. And so one of the things that I did in conjunction with the Children's Advocacy Alliance, and it's me as a dad struggling to figure out my own family couldn't do this alone. It's only with partnership with people who understand the system in general. So I partnered with the Children's Advocacy Alliance and asked to say, what is the best in the country? How can we replicate that? We ended up bringing a group in from Oregon, Balmer Institute, and it's a part of their university where they really focused in on developing an undergraduate program for children's mental health. Many of these ideas Ms. Weeks mentioned in her comments, and I'm going to talk about those briefly, but this undergraduate degree in children's mental health is important because across the country, you don't specialize in children's mental health, you specialize in mental health and then fall into children's mental health. And so in the Balmer Institute, they focused in on developing undergraduate professionals who have an understanding of what children's behavioral health looks like, an understanding of some of the mitigation strategies and the connection, that connective tissue to a system in order to connect children. And so what we did was we brought in the University of Nevada, Las Vegas, University of Nevada, Reno, Nevada State University, and asked them if it was possible. I think there's an enormous opportunity right there if the state were to help us get that off the ground. And I want to take just a moment to say what makes an undergraduate professional different. One is if in the medical sector you have doctors and you have nurses, so you have a graduate degree, you have an undergraduate degree. You don't have that same thing in mental health. And I think we absolutely, definitely need it. If I put my councilman hat on for a second, I spend quite a bit of time with teachers and principals. I think you can, while it's my experience and anecdotally, I think you can very clearly link the number of absenteeisms. I don't know if you've seen reports on that, but absenteeism right now in Clark County School District is off the charts. I think you can link absenteeism to this because I can see kids who may not want to go to school and parents who may not want them to go to school because of some behavioral health issue. The number of teachers leaving the system, having spoken to them, it's directly tied to children who they're having a hard time managing them in class. And I can tell you from personal experience that COVID exacerbated whatever was happening already. COVID made it significantly worse. And so principals are losing teachers. Teachers can't stay in the classroom. Absenteeism is at an all-time high. And this creates the perfect opportunity for the state to jump in and create something new that will take some time to develop, but will have an opportunity to rectify what I think is a system that's non-existent. With that, Mr. Chair, I'm happy to walk through these recommendations. I'm just going to read them and talk about kind of how they came about, and then I'll open myself to any questions you might have. So the first one is the Office of Children's Mental Health.
A quick question. As you're going through them, can you state how much they're going to cost? I think that would be helpful.
You betcha.
Thank you.
The first one, the Office of Children's Mental Health, I don't think this is a significant investment. I think this is, the state already has something like this in the behavioral health boards in the north and the south. What I'm saying is probably within the Medicaid office, and you heard Dr. Weeks talk about that professional clinician who's focused in on children's mental health. I think it's building out 2 or 3 people to help staff that. Within Medicaid or within DHC, or the other one, public health, either one of the divisions within DHHS. What I think it is creating a connection to who gets licensed within our state and a matrix of those folks so that we can help them connect with each other. Create that referral network. I don't think that's the significant investment from the state of Nevada. I also think it's helpful as every 2 years you meet to have someone with direct experience working in children's mental health can talk about who's part of the system, who's not part of the system. I would also recommend funding a study around why providers are not enrolling in Medicaid or why not they're credentialing with health insurance companies. I think that is going to be a critical investment. When it comes to Number two, prevention, the oriented, this is Bachelor of Arts Mental Health Training. We have a proposal in with DHHS now. We've been working with Director Whitley and Administrator Weeks and several members of their team on what that funding would look like. And while the immediate thought is going to the state general fund, the state has access to multiple funding sources, and I would recommend your use of opioid settlement funds to fund this. I think there's enough funding in there, and I think there's enough creativity. I also think this mitigates the impacts of what Administrator Weeks was talking about when it comes to comprehensive screenings and assessments. When she mentioned that happening in schools, right now there is no personnel to do that. So what I'm offering you is a solution to some of the opportunities that she suggested. We also, Senator Wynn mentioned care coordinators. A BA level professional is the right kind of person you want in that care coordination experience. And so we have a funding model in with DHHS. We're advocating for the opioid settlement funds to get the program off and running with the University of Nevada, Las Vegas. And DHHS has recommended bringing on somebody at UNLV to work with Medicaid to figure out how we can build in CPT codes, Medicaid billing codes, so that Medicaid can eventually fund those positions, whether they be in a school system or a hospital system or any other system. So I think that one is should be ready to go anytime you're ready. On the third, funding child-focused mental health graduate programs. We also have a proposal in with DHHS, again, around the opioid settlement funds for the University of Nevada, Las Vegas, to fund additional graduate level programs. So as we build out that undergraduate workforce, we want to have more graduates, a graduate program level professionals in that space as well, to get to that early childhood assessment, diagnosis, treatment. You want to have graduate level professionals in that as well. Streamlined licensure and accountability processes for clinicians. This is recommendation number 4. I've worked with several of you. This is a common issue with the medical community in general. I can't figure this one out, to be honest with you. I think it's absolutely critical the state jump into licensure, and how we do that, I don't know. I'm going to defer to you because I don't understand what stops it. And I'm getting a smile from the Assemblywoman over there. We need to get people licensed in an appropriate time frame because the barriers to licensure stop them from wanting to come to Nevada. How we do that, I'm not sure. Number 5, bring reimbursement rates to the national average. I think Administrator Weeks had already mentioned this. This is something that I think you have a cadre of supporters in this mental health community that want to work with you on that. If we need to identify certain codes that make it more financially feasible, I think that's appropriate, but taking some step forward so that we can get children into care. And reduce reimbursement barriers for providers who support Medicaid clients. This is into that study of why we see so many people leaving Medicaid or not signing up for Medicaid in general, understanding it. And so I know the cost question comes up all the time, but understanding what prevents them from signing up for Medicaid is, I think, the first question that I would ask. And then early assessment intervention for specific child mental health diagnosis. That's probably a little bit more complicated. It gets into the more graduate professionals that we have within this space. So Senator Dante, you asked me for a specific dollar figure. The dollar figure is with DHHS right now. I think it's well within the means of the state of Nevada outside of your general fund. I think it's within specialty funds, and I think it's not reoccurring funds that are the issue. It's setting up a system that's the issue. And so I strongly encourage you to, if this is appealing to continue to work with this coalition of folks behind us, and we would absolutely support the next steps. And I'm happy to answer any questions. There's a whole bunch of professionals behind me. I'm just a dad trying to make it easier for me to navigate a system for my kid.
Thank you so much. Any questions from committee members? Assemblywoman Brown-May.
Thank you. Thank you, Councilman, for being here. Really appreciate the presentation and all of your hard work on these issues. My family also has diagnoses in their history, right, and understand what it's like when your family is trying to address your needs and keep your family unit together and healthy. So I appreciate your work on that behalf. My question is relative to number 2, the prevention-oriented BA in mental health training. I was recently at a conference where we talked about eliminating barriers to entry for some of these professional or bachelor level positions, right? So if I am 18 years old and I go to college and I decide that I want to study social services, but I don't know that I want to pursue professional licensure because of the cost associated with a medical degree, right, or licensure, I don't know that. And I end up on a path that my counselor has given me as my preferred direction at that point. And I take a number of classes and invest in my education and then decide that I see something really important and I want to go into this. I want to go into mental health, but I have a dozen classes or half a dozen classes that now don't apply to this degree. I'm curious to know, is there a way that we can work through NSHE that we can help to streamline preliminary work done by our students to help them move into this type of field when they discover it's their area of passion, right? How do we get psychology classes, sociology classes, biology classes, all applicable to this bachelor's degree program that would help a student move into mental health services when they discover that's really what they want to do? And I guess it's probably a question for more of those behind you, given where we are in higher education and in NSHE. How do we help students navigate the list of classes that they have when they declare a degree program, right, a major, and then pivot their major? How do we help them not waste dollars and get them where we need them to be in the end? It's kind of rhetorical, but I'm going to just throw it out there to the community behind you.
And I'm always comfortable talking. Michelle Paul is the vice president of the mental health programs at university, and she's here if you want her to come up and speak. But how I look at it is UNLV expressed interest in developing this program. I know it's multi-department, so it's not just it's not in the education department, but you have psychiatry, you have social work, you have public health, and you have multiple departments that are contributing to the curriculum and the development of an undergraduate program. So students within any of those disciplines have access to courses that are multidisciplinary. I think for me, one of the most exciting parts about even talking about this, because it really doesn't exist anywhere else in the country, is UNR is interested in developing a micro-credential. And so for all those teachers that I mentioned that are leaving the classroom because they can't figure out how to deal with quite difficult children, giving them a 6 to 9 credit course to say, here's some skills on and how you manage those children. And maybe that's become part of an incentive through their hiring authority, whether it be CCSD or a private school or a charter school, or maybe they're a Boys and Girls Clubs employee, and they get 6 to 9 college credit courses to teach them how do you recognize a kid who's struggling, and how do you provide a starburst as opposed to having a kid sit in the corner by themselves. I think there's lots of opportunity there, and I think it opens itself up to people who have thought about this field before.
Thank you. I appreciate that follow-up. I would look forward to continuing to work on that in particular so that we can help our students gain access to mental health as part of a BA program. I think it's really important that we do that. Micro-credentialing is really going to be a great way to go. I know that I have a teacher who's 23, right, who minored in special education as a way to be able to supply some of those high behavioral support needs, right? Positive behavioral supports is a great way to go about serving our students. And then on number 4, I just have to concur, right? Streamlining the licensure, you know, we've talked a lot about, and I would be remiss if I did not put that publicly on the record. We continue to address that with all different types of licensure boards so that we can get professionals into the field. So I appreciate your work there as well. I will follow up with you in great detail. Thank you.
Thank you.
Thank you so much. Senator Nguyen.
I see that these are listed 1 through 7. Is this like a priority list of 1 through 7, or is there anything I should take away from these numbering?
My recommendation is all of them starts a system. I don't think I think Administrator Weeks mentioned multiple versions of these priorities within her presentation. This provides you a game plan as to BDRs. And I think any one of them is worthwhile ongoing. And if you're only able to get 2 or 3, great. If you can get all 7, I think it becomes the beginning of an actual children's health system here.
Thank you.
Thank you. Assemblyman Nguyen.
Thank you, Chair, and thank you, Councilman, for being here today. I know that just echoing what Senator Nguyen asked in terms of the list of priorities and trying to figure out how we can deliver kind of like a wholesome situation, and as we try to solve problems, we don't want to create new ones. And so one of the things that I've always been pretty much broken record about during my time here in the legislature is ensuring that we kind of do 10 step forward but not take a few step back, and then because we forgot to do certain things. Where are your thoughts, and maybe this is also, back of the room conversation, is looking into the cultural competency piece, as Nevada's, going to be more diverse, and there's a lot of layer with the diversity and communities that are now making Nevada home. And of course, I represent a very diverse district in District 8, and I want to make sure that we have some of the priorities here addressing language and cultural barriers. So any thoughts on your end on how we can accomplish that with, of course, all these priorities in mind?
I think it's an excellent question. When I brought together with the support from the Children's Advocacy Alliance, anybody involved in children's mental health, it was a broad range of people who came forward. What was interesting is leaders yourselves, as you try to build consensus amongst a committee or amongst the legislature, it's hard to build consensus. These priorities were not hard to build. Everyone was consistent in their thinking, which is nice. It makes it easy as an elected official if you can build consistency. One of the things that came out, and I mentioned it earlier, is there isn't a connection point for these groups of professionals. They're not meeting to confer upon what's best for children. They have individual online trainings, or they can go out of state for trainings. I think the best way to build cultural competencies is ingrain it in the education system. And so as we develop undergraduate students or develop graduate students, incorporating that kind of training, that kind of awareness about what our community looks like and speaks like and feels like, I think you have to incorporate that into education and training, and that can only happen in a higher education setting, as we recommend in these sets of recommendations. I also think it's important to continually bring people back for that continuing education within Southern Nevada or Nevada, so that they understand the changing landscape. So I think the best way to identify and to bring about resolution is to incorporate that within the university.
Thank you so much. Senator Nguyen or Assemblyman Gray, do you guys have any questions? Senator Titus.
No, I just want to thank the councilman for a very thorough and thoughtful presentation, and I concur about the need for, especially the reduction in obstruction to licensure and streamlining that. And I truly would like to see perhaps a mental health licensure at, just one where everybody goes. So thank you for bringing this up.
Thank you so much, Senator Titus. Yeah, I would agree. I think in some of these, we've actually heard similar themes. For instance, when talking about licensure, I mean, we started off our hearings earlier in the year talking about licensure in healthcare, and I think, in Stacey Weeks' presentation earlier about fee-for-service, traditionally healthcare has always been fragmented. We refer the problem to someone else to take care of, and so I think we need to focus more on having a centralized system that sets the goals and the parameters, and then empower our physicians and local practitioners to actually deliver the care. I think that's kind of what you're alluding to, at least with your Office of Children's Mental Health and so forth. So I think we all greatly appreciate your service and your personal experiences, and I think we all definitely will look forward as we explore what potential BDRs we can introduce. So thank you so much for being here. I don't know if you have any closing remarks.
I have one last comment, and just to put on the record, because I know you asked for dollar figures, what I want to say is, having worked around education and children for so many years now, for children that struggle, that miss more than 10 days of school in a school year, they're considered chronically absent. They really struggle learning how to read. And so this is true in kindergarten through third grade. If you don't learn how to read by the time you're in third grade, there's an 80% chance that you're 80% less likely to graduate from high school. So having personal experience with the Boys and Girls Clubs, what you see is children who can't read end up dropping out of school around 8th grade. Those are the children who we're seeing in UMC ERs right now, in jails right now, and struggling with the criminal justice system. That is far more expensive than what we're proposing here. I do have dollar figures outlined for each of these recommendations, and I'll be happy to send those to the committee so you're familiar with what we're working with the Department of Health and Human Services on. And I appreciate your time and your investment in this conversation.
Thank you so much, Councilman. We'll go ahead and close this agenda item and move on to our next one, which is agenda item number 7, a discussion of the behavioral health challenges among tribal children and recommendations to the committee. With us, we have Ms. Angie Wilson, the Tribal Health Director for Tribal Health Center, or Reno Sparks Indian Colony. So welcome back. We loved your presentation so much that we welcomed you back for the second time. So please begin when you're ready.
Okay. Can you hear me okay?
Please proceed.
Okay. Waklisi Samax. Tusika Madiksha. Tusisunwi Iligatageci Angie Wilson. Good afternoon. I appreciate being welcomed back. Thank you so much. It's a pleasure to be here today. I'm here with Councilman Thomas from Duck Valley, who will be talking a little bit about a situation in his community at the end of this presentation. I'd like to first express my sincere gratitude to Senator Donate and the Nevada Joint Interim Committee on Health and Human Services for the invitation to return and to discuss the behavioral health challenges for our tribal youth, an important issue for all of our tribal nations. We're grateful to and proud of the committee's inclusion of our tribal input and encourage you all to continue this incredible effort moving forward. Thank you all for your time and consideration today. And as you know, the Reno-Sparks Indian Colony has been out attending the HHS Region 9 Tribal Consultation Meeting, and then immediately following that, the National Indian Health Board Annual Tribal Health Conference. And so we were unable to submit these documents to you ahead of time, but we'll submit our written testimony and supporting documents to you this week. As detailed in my prior presentation to the Joint Interim Committee in February, it's the responsibility of the federal government to uphold its trust responsibility to our tribal nations. And as an American Indian, a healthcare advocate, and as elected tribal leadership, we always have to keep that in the forefront when we're talking about the health and wellness of our Indian people. As presented and in review, our American Indian and Alaska people face some of the greatest challenges to our physical health, mental health, and well-being of any ethnic or racial group in the United States. And although disparaging outcomes, our tribal communities continue to represent strength and resilience despite a history of genocide, cultural assault, and systemic oppression. And just an overview from our last time we spoke. According to the Office of Minority Health, in 2019, suicide was the second leading cause of death for American Indians and Alaska Natives between the ages of 10 years old to 34. Our adolescent females aged 15 to 24 had a death rate that was 5 times higher than non-Hispanic whites, and our males 15 to 24 had a death rate that was twice that of non-Hispanic white males in the same age group. Our American Indian and Alaska Native people are 60% more likely to experience the feeling that everything is an effort, all or most of the time, as compared to non-Hispanic whites. Violent deaths, unintentional injuries, homicide, and suicide account for 75% of all mortality in the second decade of life for American Indians and Alaska Natives. While we're here today to discuss the behavioral health challenges for our tribal youth, we must understand that this is not entirely possible without addressing the dynamics of the tribal communities at large. And oftentimes, extenuating and intergenerational circumstances directly impact our youth. Issues such as domestic violence, alcohol, and/or substance use can greatly contribute to the dynamics of a household, leaving significant gaps in the psychological needs, safety and security, love and belonging, self-esteem, and self-actualization of our tribal youth. And the numbers in the statistics you're hearing are our relatives. They're our loved ones, our children. But it's important that you understand the behavioral health needs that ripple through our communities and the serious need to be appropriately and culturally responsive in serving our tribal communities. And so today, what we talk about is not focusing on the symptoms, alcohol, drug abuse, but knowing that the hurt comes from historical intergenerational trauma. Today, I want to express my gratitude to the family of Amanda Davis for allowing me to tell her story in an effort to bring awareness that these are not just numbers or statistics, and the need for true behavioral health interventions are much needed to bring change in our tribal communities. So just before Christmas, which is supposed to be a time of joy and celebration. Amanda, who's a beautiful mom of 3 children, is 7 months pregnant. She's been in a long-standing domestic violence relationship. And as you know, it's really difficult for many women in that case to leave domestic violence situations. But she had made her decision to leave the relationship earlier that day. So in that evening, when the whole family went to sleep, in the early morning of December 15th, her 15-year-old daughter was awakened by her 8-year-old brother, reporting to her that their mom was being stabbed by the boyfriend. The daughter immediately called 911. Amanda broke free, and she made it into the room with her children, all of them working hard to barricade the door with furniture. The perpetrator broke into the room, and they began to drag Amanda out of the room, while her children, all 3 of them, adamantly tried to fight him off of their mom. He continued to drag her into the bathroom, where he repeatedly stabbed her. The children ran for help, and the perpetrator fled the scene. While emergency services arrived trying to save her life, she and her unborn boy, Ezra, succumbed to their injuries. Amanda's mom and auntie arrived on the scene, having to break the news to her children. The impact of this incident is not just a simple ripple. Rather, it's a tsunami hitting the entire tribal community. And for a moment, I'd like the committee to imagine the generational impact this situation right here will have. Imagine the impact to her children, long term, her mother, and her extended family. The significant range of feelings and the loss of their mom, their inability to help her in that moment that they'll never forget, and of course the significant grief and loss. And then for the heartbreak and trauma and having to relive this horrible incident through the court hearing that happened just this past September. If this wasn't hard enough, just after that, earlier this year, Amanda's mom lost her grandson in a traffic accident east of Reno. I want to acknowledge their heartbreak and honor their resiliency to continue to hold on when I know that is pain that some of us can't even imagine. I want you to consider Maslow's hierarchy of needs. How can we begin to consider the significant impact to this family and to the children, the grandparent, to ever achieve sexual or self-actualization at the highest level of that scale? The importance of appropriate assistance and access to behavioral health services is so paramount. As such, I'm going to share some barriers to such care, and I'll make some recommendations for assisting and resolving them. Stigma and shame associated with seeking behavioral health services is one of the most consistent barriers across our tribal communities. It's always been. Our American Indian people have described this stigma about seeking services and concerns. They look at it as being weak, or, hey, you're crazy. Or you get a lot of shame and how others will view you. Oftentimes our youth are told, hey, snap out of it, or you'll grow out of it, or stop crying around and man up, leaving tribal youth to feel isolated, alone, and unsupported or treated for behavioral health needs. Sometimes the interactions of what's going in the family unit make it really hard because the family doesn't want their business to be out so nobody can seek help. Other barriers include concern about maintaining privacy, and this is especially true in small tribal communities. Sometimes you may have family members working at the tribal health clinic, or relatives, or concerns that someone might see you while you're in the behavioral health services, and there's always fear that your confidentiality may be violated, so people don't access care. Mistrust of providers can also present challenges for our youth to obtain services. Non-Indian clinicians sometimes may not understand the dynamics of multi-generational homes or common disparities within a tribal health setting, leaving youth to feel disconnected from their clinician or sometimes judged. Transportation issues also cause barriers in obtaining care. In addition, parents are not able to leave work or afford to take time off due to rising costs, and this leads to the inability to access groups or individual therapy sessions. In addition, the Nevada tribes have been addressing concerns with non-emergency medical transport services, and we thank the Nevada Department of Healthcare Finance and Policy for their assistance on this important matter. Lack of tribal behavioral health workforce to keep up with the growing demands of our tribal communities. This includes challenges in recruitment, retention, salaries, etc. Healthcare workforce is the highest issue noted amongst all 12 regional areas of the Indian Health Services, spanning concerns of Indian health, tribal health, and urban Indian programs across the nation. It's the #1 hot topic. Lack of non-tribal behavioral health providers willing to see children or youth at the local level. Many of the providers in the local areas are unwilling to provide care to youth, causing significant backlog in access to care for behavioral health needs. Lack of Medicaid providers willing to take or see children and youth continues to be a growing concern. Medicaid coverage in tribal communities is high. We have a lot of folks on Medicaid, leaving many of our youth without a viable option to access care, and this is becoming a growing issue for our patient populations. Lack of cultural competency can derail the trust of American Indian patients. In addition, impact the ability of our youth to see a pathway forward for cultural revitalization or cultural connection. Cultural-based practices are significant in the healing of our American Indian youth, our families, and our communities at large. I want to talk a moment about traditional views of mental health, healing, and wellness. When addressing the needs of mental health care in tribal communities, it is vital to understand that there are cultural views, traditional ways, and cultural practices related to healing and wellness. Our traditional beliefs and practices can include things like prayer, ceremony, storytelling, traditional medicine, and cultural practices to sustain balance and wellness. As evidence, there's a direct correlation between historical trauma and depression, anxiety, substance abuse, suicide, and chronic disease. As such, effective interventions for American Indians should always be focused on cultural-based practices at both the individual and the community level. This includes, but is not limited to, the revitalization of our languages, engagement with cultural practices, and reconnection to the land. Western mental health care is different from traditional belief systems in a number of ways. And as I discussed in my last presentation to the Joint Interim Committee, the 9 Oregon tribes developed cultural-based practice document in which the Oregon State Legislature adopted into the Oregon Administrative Rules, allowing for tribal health programs to utilize cultural-based practices equal to evidence-based practices. The integration of traditional healing and Western mental health care emphasize working together on culturally based programs, respect for each system of care, and the importance of communication between the two. This effort has led to tribal advocacy across the nation and proposed 1115 demonstration waivers in various states proposing Medicaid reimbursement for traditional healing. Utilizing cultural strengths to promote and sustain wellness for culturally informed mental health care for American Indians is paramount to the healing within our tribal communities. So some recommendations for consideration is a tribal behavioral health aid program. American Indians and Alaska Natives are overrepresented in statistics defining mental health disparities, while at the same time underrepresented in the availability of mental health professionals. There's a pronounced need for American Indian and Alaska Native mental health providers and/or behavioral health aides. The state of Alaska approved the Alaska Native Behavioral Health Aid Program, which promotes behavioral health and wellness in Alaska Native individuals, for the families, and for communities through culturally relevant training and education for village-based counselors. A behavioral health aide is a village-based counselor, a health educator, or an advocate who is trained to work with community members to address behavioral health topics that affect individuals, families, or whole communities. Using a holistic approach to well-being, behavioral health assistants apply their knowledge, skills, and training to address the unique and social cultural needs of our tribal communities. They support clients dealing with issues such as grief, depression, domestic violence, suicide, trauma, substance abuse. In addition, the scope of practice can include a wide range of services, including wellness promotion, community education and prevention, case management and referrals, substance use assessments and treatment, recovery aftercare, teaching life skills and healthy coping strategies, and crisis management. They're employed by tribal health organizations and are a valuable part of the continuum of care for community members needing behavioral health resources and services. The behavioral health assistant is familiar with the local tribal culture and traditions and can provide services using a combination of traditional and Western models of care. They identify people early in their behavioral health struggles and provide direct services so clients can receive care within their community and with the support of their loved ones. If needed, they make referrals and coordinated services to higher levels of care in or outside of the tribal community. They also provide aftercare to ensure that clients have continued access to care when they return home. Over the past decade, the SAMHSA administration funded programs that have demonstrated the significant role Native community mental health workers can provide in suicide prevention, which is detailed in the National Tribal Behavioral Health Agenda. As an example, American Indian community health workers, mental health workers have delivered a culturally adapted, evidence-based intervention to youth who have attempted suicide and for their family member support. Benefits of Native community mental health workers leading this work included increased cultural awareness and understanding during the intervention, as well as openness and comfort in meeting regarding this sensitive topic, thereby reducing stigma. It would be a strong recommendation to consider this effort here in Nevada among the 28 tribal nations, as many of our tribal nations are located in frontier-based counties with little behavioral health resources. This particular program was also picked up by the Northwest Portland Area Indian Health Board, who provides the certification for behavioral health assistance to the Oregon, Washington, and Idaho tribes. Another would be to support the adoption of cultural-based practices. While we look at developing the cultural-based practices manual, it's important to consider potential adoption of this effort through our legislation here. It's imperative that the state recognize cultural-based practices as acceptable measures in the effective prevention, intervention, and treatment modalities within our tribal communities. In addition, as tribes continue to move toward CMS consideration of traditional medicine or traditional healing reimbursement allowances on a national level, the concept of mental illness and traditional beliefs have different meanings and interpretations within our tribal communities. Our American Indian people may express emotional distress in ways that are not consistent with standard diagnosis categories. Our Indian people with anxiety, depression, or other disorders will often seek help from traditional healers as their primary choice before reaching out to mental health services. In addition, ceremonial practices may result in the connection with the unseen world, not necessarily what would be considered hallucination or mental illness. Another recommendation would be child-focused mental health graduate programs. We support the need for additional graduate training programs focused on child mental health, including internships and postdoctoral fellowships. This effort would allow the increase of behavioral health professionals with knowledge and understanding of children, adolescents, and transitional aged youth at risk for behavioral health disorders. In addition, would allow further collaboration between our tribes and UNR or UNLV and our tribal clinics for fellowship opportunities. Another would be to reduce Medicaid barriers, and this is a big one. To reduce the administrative barriers and reimbursement disparities for Medicaid providers serving the behavioral health needs of our youth. While the Reno Sparks Tribal Health Center is a tribal Medicaid FQHC, it will take time for us to negotiate potential written care coordination agreements and negotiated rates with Medicaid providers. As such, it's imperative that Nevada youth are not held in the administrative crosshairs in accessing necessary support for their behavioral health needs. In addition, it's important to always remember that American Indian and Alaska Native Medicaid beneficiaries are 100% FMAP to the state. And that's a big reminder on the cost of care is a pass-through. I do want to make one more comment before I turn it over to Councilman Thomas. Earlier, during the presentation by Ms. Weeks, there was some discussion in regards to the managed care organizations or fee-for-service. And I will tell you that there are significant issues when it comes to managed care organizations and the tribal programs. Here in this particular state, we have 2 counties that are mandated into managed care, Clark County and Washoe County. So the Reno Sparks Indian Colony's Tribal Health Center is directly impacted by this. But I will tell you, I do sit on the National CMS Tribal Technical Advisory Group representing the Nevada, Arizona, and Utah tribes. And I can assure you, across Indian country, managed care organizations with Medicaid have been a significant barrier for tribal programs across this nation. So much so that we've had to develop a subcommittee to address how to educate people about the toolkits and build a toolkit for the provisions of American Indians and Alaska Natives, so we don't get people caught in the crosshairs of not understanding the provisions of what tribal clinics are allowed to do and access to care for our Medicaid beneficiaries. So I hope that while we are talking about fee-for-service, it is that fee-for-service directly impacts the Reno Sparks Indian Colony, and I would venture to say that when managed care is rolled out for the rest of this state, we'll start to see those issues in tribal communities across this state as well. And so we'll do our best to continue to educate our other tribal programs and support the managed care organizations, but I will tell you it is a heavy lift for the tribal health programs. I also just want to talk a little bit about, I really do believe that Nevada is a great state and we've been very innovative on a multitude of things. I really do believe that even though we hear, there's opportunities for fraud, there has got to be a better design to reduce administrative barriers for access to behavioral health services, especially for youth and needing those services. And I believe wholeheartedly that, we've got some pretty smart folks here in the state that could really address those particular needs. So at this time, I just want to say Sepkecha. Thank you so much for allowing me to present to you today. And I'd like to introduce Councilman Thomas from Duck Valley and give him a few moments to speak.
Good morning. I'm a councilman from the Shoshone-Paiute tribes of the Duck Valley Indian Reservation, chairman and the committee. My name is Brian Thomas. And I want to start out with a big thank you to the State of Nevada Department of Health and Human Services for being there after in 2020 we had a line of about 6 suicides within 5 months. And they showed up there Christmas Eve, and they spent the weekend there. And that was really touching to the community, the people that went and visited them. Because of the losses, the 6 losses, there was a lot of children that were in part of that loss of their parents, and some young children that was in a suicide. I want to do that, and then also inform you that we had some success with the Army Idaho National Guard, bringing them out there during the time of our need for our EMS, EMTs, and our healthcare providers, as well as our BIA police, to help talk with them about suicide, how they've managed, and just share their thoughts with them. And that really helped the community out a lot, especially the EMS. And the part of the EMS that really impacted was my brother. And in the closing, I'm going to tell you the story about how it impacted my families. But going back to the children that are being discussed today, our children go to school, tell the teachers of abuse. And if a child at a young age tells the teacher that there's abuse within my family or I'm being abused, it has to be addressed to the next level. However, that's not happening. This has come from a grandparent that called me. I wasn't with the business council or anything. He asked me, how could I approach this? How could I do this? How could I make it better for myself and my grandchild? And I couldn't really answer it. But I found out today that the school teachers are to report each and every single one of them. And, the teachers, and then also there's a lot of favoritism going on in schools, what you could help us fix at the state level, of favoritism and bullying from teachers. There's a lot of complicated emotions that are bringing with this into the school system, where children are not wanting to go to school, not wanting to learn, having a hard time understanding, paying attention, staying awake in school because of the hard times they're getting at home. That's kind of what I wanted to just tell you about, that was brought to me by a family member. And the empathy of seeing that with the close connections with family members, it is very, very heartbreaking emotionally to myself or to the people that have given me a call to discuss some issues with me. Especially the surviving family members, the grandparents that take care of the grandchildren today. They have a hardship. They have enough to what they have to do to provide them to survive, but they are crying out for help. And the state could help through the school system. There's a lot of children that have lost loved ones. And we can never understand why the individual took his own life, knowing that he or she has children. There's always a question that comes from the child that doesn't understand death. When is my uncle, when is my auntie going to come back that's gone for 2 years? They still ask that question. It is really hard sensing people's emotions. The children, you see it when they come to visit you. The elders say. There's a lot of Native American elder survivors that have seen many before in the past years, and it is not hard for them to accept that. State could help them. I'll cry to you for help. It is really emotionally tough for me because I'm a parent of a suicide, possibly homicide. We'll never understand it. It is a cold case. And before I say any further, always tell your children, your grandchildren, your mothers, your daughters, that you love them. No matter how hard it is, going through this tough love today with all the drugs, alcohol abuse, tell them you love them, because it's going to be a time where I wish I traded all my tomorrows for one more yesterday to say, I love you, because the person that you love might be gone. Always tell them that you love them. You don't want to say, I'll tell you that tomorrow. Tomorrow will be too late. I should have done that yesterday. You know, to elders, 2 heartbeats. 2 heartbeats I want to talk about is a carrier of life, the mothers that are so close connected to their children in the story that she told. They are so close, they buried them for 9 months. You lose a child. That is one of the worst things you want to hear. A federal police officer or a state knocking at your door to tell you, I really have some bad news. We have news that your son, your daughter, your grandchild has committed suicide. How do you take it? It's going to break you down, no matter how strong you think you are. You ain't no Superman when it comes to a death. Going back to the mothers with a close connection. Every single mother has the closest connection to their child. Burying them for 9 months and delivering them to give them life. It is not easy. You know, a death by suicide could be prevented by bullying, favoritism. When you get news like that, it is a change of every parent's, brother, sister's life. It'll change your life. It'll impact you immediately. How do you tell, or who do I turn to? I'm the oldest one in my family. I lost a son to possibly suicide or homicide. Mother's gone, dad's gone. Who do I turn to? Nobody. My aunts were there. I called my aunt I was the closest to, and I told her. And she said, just be there, stay there, be strong. I'll find a way down. I'm going to go see your boys, girls. So she shows up. You know, it's really, this is one of the toughest subjects to talk about. There's nothing harder to tell a story of a suicide or a death of a family member. This time will never, the seconds go by so fast. A 2-mile drive to the place of where suicide or the homicide happened, it felt like 200 miles. Following that federal officer, seeing the people there, that 2 seconds, minutes, the days, the weeks, the months, the years, they go by so fast, and everything after 4 years still fresh in your mind, it is really hard. It is really hard. It's so complicating in life. But we, listening to us and the state of Nevada helping us and supporting any further assistance and financially, we would very, very much appreciate it. In any way you can help. Because these stories, this is a true story I just got done telling you. Always tell your children, your mom, your dad, that you love them. In closing, that's my closing on that. Thank you very much.
Thank you so much, Councilman. We greatly appreciate your remarks. Committee members, any questions to Ms. Wilson or our councilman? I don't think we have any down here. Senator Titus or Assemblyman Gray?
Yes, thank you, Mr. Chair. First off, you touched all of us with, and thank you for sharing personal stories. I know it's hard, and as you said, 4 years ago, it still lives in front of you. Having done hundreds of hours in emergency room in rural Nevada with Native populations, I've had to deliver news of young folks that I could not save in the ER to family members, and just felt sick with them with that delivery of news. So I do, although I have not had a loved one commit suicide, and hopefully I don't have to experience that, I certainly have had to deliver that to families. So thank you for that. Having that emotional component and sharing that, my hope is that we can kind of deliver some positive changes. And so we hear about this, but again, delivering change is what's going to be the key, so we can limit the families in the future that have to experience this. Going back to your comment about the cultural-based reimbursement, that is a possibility that other states have entered into. What's that resource look like as far as, did they get NPI numbers, which is a practitioner numbers? Did they get reimbursement from Medicaid for those interventions? Do they have the resources to do that? I would really like to see some more information regarding that and deal with some actual numbers, because it seems like perhaps that is a good avenue, and is it making a difference? And how do we make that happen in the real sense?
Angie Wilson, for the record. To the committee. It's a great question. Thank you so much for having that. Right now, there is I'll just say this, there's been years of tribal advocacy for recognizing that in our tribal communities, health and wellness doesn't start and end just with Western medicine, although we really respect it. I mean, I run the largest tribal health clinic in the state, and all those priorities of primary health care is really, really important. But that in our tribal communities, there's also traditional medicine. And as far back as I could remember, there's always been advocacy to recognize traditional medicine. There's been a large push in tribal communities across the board in working with CMS to look at the possibility of actually getting to a point where we can agree on traditional medicine and what that would look like. There is a White House task force working specifically with traditional healers across the nation in this conversation that we're having. And when I say there's multiple states that have put in an 1115 demonstration waiver that has not been approved yet, those issues are still under discussion with CMS at this point. But I think that the reality is they're not in discussion to stop the discussion. I think the discussion has been closer than it's ever been to looking at pathways of what that would look like or be authorized under the Centers for Medicare and Medicaid Services, specifically for Medicaid reimbursement for traditional medicine. And I think that all of those underlying things, like one of the big issues is tort. How would tort coverage come through that? And so those are still things that are in discussion, and it's just really a different concept to think outside the mindset of what a regular provider with an MPI would look like. Tribal health facilities bill under the tribal clinics MPI, but it is getting the authority or the authorization and working closely with CMS on a national level to see what that will end up being. But I will say that I'm proud of the level of advocacy happening in that direction, and I'm hopeful that in my lifetime we'll see that come to fruition.
Oh, thank you for that. And just kind of a follow-up on one of the things that we in healthcare certainly have looked at is making sure that we have patients do best if they have a provider that looks like them or that comes from the same background, that they really feel they can communicate. And we've heard that conversation multiple different committees that I sit on. And I'm just curious about the pipeline of Native children in your schools. Is there any state people, anybody reaching out to you to encourage your children to go into the STEM programs, the healthcare science programs? Are we reaching out to those schools, those school children to become providers, physicians like myself? Do you see anything from the state, anybody coming out to help with that pipeline so we do indeed capture the brilliant students that are out there in your culture to become healthcare providers?
Actually, I've worked closely with Nevada Works and Thurman Roberts, who's a tribal representative with Good Jobs Nevada and Nevada Works. And we actually hosted one of the first events at our clinic to encourage youth to consider going into the healthcare field, especially with the tuition program that was passed here in the state, which is really great to be able to start looking at people getting into the field in any aspect where they want to be a doctor or for you, Mr. Gray, on the EMS side and all of that. So it's needed across the spectrum of healthcare. And so those are all things that we're looking at encouraging. We had a really great successful event with starting those wheels turning and what that could look like. I would also say that one of the things I will be working on, whether it's something that comes up right now but I will tell you, one of the things I will be working on here in my advocacy in this state is to look at the behavioral health aid program. And a lot of the reason why is because those clinicians of what's been done in Alaska or what's being done with the Northwest Portland Area Indian Health Board and the tribes that are operating the behavioral health aid programs under that is these are folks that are from the community, go through training, go through that certification process and work under a certain level provider, but are really out in the field with more immediate help right now, because we know that pipeline to get our kids through the system where they become providers takes time. So that's kind of what we're looking at doing. I'm really proud of the effort in working with our cohorts and our collaborative networks in our community.
Great. I'm glad to hear that, because I've had the privilege of working with Dr. Lauren Simpson and Dr. Sharon Malott, both native Nevadans who I feel really make a difference by being there. So thank you for that. Good to know we're doing something positive.
Thank you, Senator Titus. Any other questions?
Yes, sir, just real quick. And Dr. Titus literally took the actual question out of my mouth, so that's good. We were thinking along the same lines. But with that behavioral health aid program, that may be an opportunity to identify kids that have an interest or members that have an interest, be a great feeder program into other aspects that then can come back. I mean, there is nobody better, culturally that'll be able to understand you than your own people and be able to work with those issues. I mean, we can try, but we're never fully understand. So, I stand ready to help you guys any way you can to get those programs up and running and help you in that aspect.
Thank you. Quick question for Ms. Wilson, and then we'll break for lunch. So I was reading into the behavioral, hold on, let me look back at my notes. So the behavioral health aid program, how it grew from a statewide counselor in every village initiative, and how now there's like different levels of tertiary services. So there's a training center, there's like resources, there's an apprenticeship program, there's technical assistance for the tribal health organizations throughout the state, and then it goes into certification, as you mentioned in your presentation. So do you envision, so for such program to be established, say the committee created a BDR to stand this type of programming in this state, do you see that administered by DHHS, or is it by the Nevada System of Higher Education, or is it by the tribal organizations itself? Like, how would you, and I know this is kind of a continuation to the discussion that we had back in February, where what is the model that we need to follow as a state to help empower our tribes, but also set up your own streamline and autonomy to making sure that we're actually delivering care? Is this a subset of that, or I guess what would be an ideal situation for how this program is ran and who is administered with making, or who is tasked with making sure the program runs efficiently?
Thank you, Senator Angie Wilson, for the record. In all of the cases that run the behavioral health aid programs and certification, they're all tribal organizations. So I would say that the preference would be that certification would fall under the tribal sovereignty, but in collaboration with the state and ensuring that certification meets the threshold there. I think it's one of the biggest programs that could really have an immediate impact, even in just starting off the program, and I will just say, there's a lot of really great work happening out here in Indian country, and it's really not necessarily us having to even reinvent the wheel. There is remarkable work being done, and I think that our colleagues at the Northwest Portland Area Indian Health Board or the Alaska Native Health Consortium would be more than happy to assist in getting us off the ground with looking what that could look like. So that's, would be the preference.
Thank you. And then thinking more short term, and just refresh my memory, I'd appreciate what the question I'm about to ask. So in your tribal health center, the Reno Sparks Indian Colony, I'm assuming you're utilizing community health workers. I know that there's been nationally discussion of empowering indigenous community health workers and looking at different reimbursement mechanisms for them. What have been some of the successes you have had with community health workers, and then some challenges, and then maybe some ideas probably with how to improve the current model that we have?
Sure. Angie Wilson for the record, happy to explain. We have 7 community health workers in our clinic. These were existing staff, health educators, personal trainers, working closely with doing health education, discussions on healthy choices, physical activity. When the community health worker program came out, one of the challenges that we felt it was up against is historically the community health representative program under the Indian Health Services is one of the longest running programs of the Indian Health Services from 1969. And so a lot of our folks in our tribal clinics throughout the nation have been trained by the Indian Health Services and have gotten their certification as a community health representative. So when the community health worker was established in the state, it was something that we were already doing, but it wasn't recognized under the state. So then we had to look for funding or pull together, which some of our tribes did pull together the funds, and we hosted the training at the Reno Sparks Tribal Health Center, where folks from the state came out and did the certification training for a number of tribal CHRs so that we can get to a point to be able to get reimbursed for Medicaid encounters. Since then, the Reno Sparks Tribal Health Center has implemented a Diabetic Day where we really utilize our community health workers with that program and assistance with, helping people to learn how to make healthier choices in regards to physical activity, talk about their pathways or challenges for, motivation in that particular area. And so far, things have gone well. The one challenge that we're up against is one of our own, and that is we have an electronic health record system and building a customized template that they can document that encounter for those billable encounters, so we can make sure that we're doing everything we need to do to be compliant on our end. But for the most part, the community health worker program has been a success, and we're happy to be a part of it at this point.
Thank you. No, I think it's important that we hear those concerns, especially when, I know that there's always legislation in the last 2 sessions that I've served, we've always looked at community health workers, and it was kind of an idea that I was looking at in terms of how we bill for those workers, and the level of services that we're expecting to them. I firmly believe that if we focus more in, especially in Indian Colony where you're in farther areas, right? It's hard to staff when you're only being allowed to bill for a certain amount of increment, right? And you need to be incentivized to actually go out there in certain parts of the state where oftentimes the community health worker is going to be the only provider that folks get. So right. I'm definitely open to revisiting that for you and thinking of it, but I know that there's a greater infrastructure that we have to focus on. So just know that that's an area that I think that could be probably more short-term, and if we learn how to tighten it up a little bit. But I appreciate your comments, and of course to the councilman for being here, and we certainly look forward to working together before the BDR deadline in August. And so I thank you so much, and I don't know if you have any closing remarks.
Yes, I just want to say, Sep Ketcha, thank you so much to the entire Joint Interim Committee for really the invite to come back. And like I said, I will tell you that the Reno Sparks Indian Colonies Tribal Health Program actually won a national award for their advocacy and for the work happening at the local level. And that was somewhat due in part for being able to present to you all the very first time. And I really genuinely appreciate the opportunity to come back and have a tribal voice at this juncture. And like I said earlier in my comments, I really applaud the Joint Interim Committee for this effort. And I will come back anytime that I'm asked to have any discussion on tribal health issues or impacts to our tribal communities for sure. And I appreciate the opportunity for being here today. Thank you so much. And again, for all of your continued hard work with everything that comes your way under Health and Human Services. Thank you all for your service.
Thank you so much, Ms. Wilson. And if we end up going to Carson City anytime soon this year, I would love to do a tour of your facility, and I'm sure other legislators would love to be a part of it. That concludes this item. The next item is agenda item 8, which is a presentation on the children's mental health services across Nevada, gaps and challenges in the system and recommendations for the committee, followed by agenda item 9. So these two items are structured kind of similarly, but you'll see the deviation. So we'll have folks come in. So we'll start off with the Division of Child and Family Services, followed by Clark County and Washoe County. And so we'll start from the baseline, looking at children's mental health, then go more specific to the localities. And then the following presentation item focuses more on child welfare. So kind of similar, but kind of different. And so we'll look at the foster care system, et cetera. And so it'll follow the same way, baseline followed by the localities. We'll go ahead and return back at 12:36 from lunch, and so feel free for folks to take a quick break, and then we'll see folks soon. Thank you so much, and we are now in recess. Welcome everyone back to Health and Human Services. We're going to start off with agenda item number 8, which is presentations on children's mental health services across Nevada, gaps, challenges in the system, and recommendations for the committee. With this, we are going to start with the Division of Child and Family Services with Administrator Marla McDade-Williams and our Deputy Administrator, Ms. Wade. So please begin when you are ready.
Thank you, Mr. Chairman and members of the committee. For the record, Marla McDade-Williams. I serve as the administrator for the Division of Child and Family Services in Nevada's Department of Health and Human Services. In Las Vegas, you also have with you Dr. Jacqueline Wade, who is our deputy administrator for residential and community services at DCFS. So I will just quickly go through the slide deck for you. Today we are here to talk about an overview of children's mental health services provided by DCFS, as well as the discussion of challenges with children's mental health in Nevada. Having technical difficulties here. So the early child, so we have a number of services. DCFS we are a provider of services, and I believe our role is to fill gaps in the community. So we are not out here to replace any services that are provided out in the community. We are a provider, and as such, we also submit to Medicaid for reimbursement where we have clients who are Medicaid eligible. But Medicaid is the payer of services, and we, like I said, fill gaps as it relates to children's mental health services. So we offer a number of services for children, essentially children and families ages 0 to 17, depending on what their needs are. We recently stood up a latency day treatment program. It is fully operational in Las Vegas, just again in response to gaps that we identified that are needed in the community. We offer mobile crisis response as well as wraparound in Nevada, which is a program sustained in statewide. We also have inpatient facilities. See, I don't know why I'm struggling here, this laptop. Patrick, help. It's showing on my screen here, but it's not showing on the... There we go, resume slideshow. There we go. Okay, so in terms of inpatient facilities, we manage a state licensed psychiatric hospital for children that currently, I believe, is up to 17 kids, ages up to 17 years old. We have a state licensed psychiatric residential treatment facility in northern Nevada. And then we also recently, over the summer, contracted out to a private vendor who is operating in a DCFS building as a residential treatment facility. And that is fill services that were previously provided by state staff as OASIS. But we provide the payment for that facility sits in our facility and bills Medicaid as well and bills private vendors as needed. We also have funded an intermediate care facility and leased a building to Clark County for boys with significant needs related to developmental disabilities, and it's a 6-bed residential setting. And then we have a current proposal to renovate a building on the West Charleston campus that may be used for girls with developmental disabilities, also proposing that as a 6-bed residential facility, potentially double occupancy depending on the acuity level of the potential residents. Through ARPA funding, we funded Connect Nevada, which is care coordination provided by Magellan to support children and families who are at risk for out-of-home placements or other family disruption. And that also includes peer support services. And again, ARPA funding allowed us to stand up the latency day treatment program. Why does it keep going away from it? Close everything and start over. Okay, Patrick fixed us. In terms of challenges and gaps, as I noted, we are a safety net provider. Like everybody else, what you heard today, there is a lack of access due to providers not enrolled in Medicaid. Youth are coming with very complex behavioral, developmental, and psychiatric needs. Juvenile justice involved youth with behavioral, developmental, and psychiatric needs are very difficult for us to maintain in our juvenile justice facilities. And then there is just a lack of third-party entities to manage facilities, such as Enterprise, which is here in Northern Nevada, which right now is also a facility that is vacant. And we had contracted that out, but we are going to have to go back to the drawing board on that particular issue. I will say anecdotally, and it didn't come up in the earlier presentation, but there are vacant wings of children's psychiatric facilities in Nevada, and it not necessarily because of reimbursement rates, but because of the cost of doing business is so high, right? After the pandemic, costs for nurses, salaries just increased significantly, and it's making a challenge for everybody, private sector as well as us, to actually maintain nurses and have staffing in all of our facilities. So again, Desert Willow has significant vacancies in and in our non-residential programs, we also have significant vacancies. In terms of step-down facilities, as part of a system of care, we could have more qualified residential treatment programs, intermediate care facilities, partial hospitalization programs, intensive outpatient programs, and some of the services that are being stood up by Medicaid hopefully will help these issues, but we're all facing the same challenges throughout the system. Again, just a very brief overview, and I am happy to answer any questions.
Thank you so much. Committee members, do we have any questions for Ms. Marla McDade-Williams? Assemblywoman Tracy Brown May.
Thank you, Chair. Thank you for the presentation. I just have one quick question. You talked about the proposal to renovate a building on the West Charleston campus that may be used for girls with developmental disabilities as a 6-bed residential setting. I'm just curious, will you clarify, is that state operated or would that be county or potential private provider?
So the plan is that we will, through ARPA funding, do renovations to the building. Right now it's served as an office building. We'll renovate it back to being the residential facility, and then we'll issue a contract to see if we can get a private provider to come in and meet that need as well.
Thank you for that clarification. Do we have any intermediate care providers currently providing that service in Nevada, or is that an area we need to grow?
So I was afraid you were going to ask me that question. For the record, Marla McDade-Williams. I am aware of a provider who would bid for that particular service, but as far as the broader spectrum, not under my purview. We are responding to a need, again, for the foster care system and juvenile justice system, and needs that we have identified for youth coming through there, and that is why we are moving in this direction with this particular facility. And I will say, while I have the floor, Administrator Weeks has worked very closely with us as we identify issues, and one of the issues that we identified, for example, is that we have youth coming into our facilities, but they also need ABA treatment, and because an inpatient residential facility can't bill twice for an ABA service as well as the residential service, Administrator Weeks has worked with us, and ABA services will be allowed to be provided at the same time. So we'll basically either bring them in on contract But, whatever their identified need is, they will be able to get that service in addition to the residential treatment, at the same time, billed separately. So Dr. Wade will have more details about that if you want to know more about that. But I'm very excited about that. And again, very appreciative of having Administrator Weeks available to actually help us really problem solve and navigate through the things that we are finding as, we have needs in our communities.
Thank you so much, Senator Nguyen.
Thank you. And I'm not really sure, Chair, if I should ask this now or if Ms. McDade-Williams is going to be around for the next presentation on child welfare services. I know there's a representative from DHHS. Will you still be here, or should I ask you my question now?
No, I'll be here. I'm doing that one as well.
Okay, then I'll just wait till the next agenda item. Thank you.
Thank you. Any other questions for committee members on this presentation or for Ms. McDade-Williams?
Mr. Chair?
Please proceed.
Thank you. So thanks for the presentation. I have a question on page 6, number 2 on staffing. And so when you say the private sector has closed wings and facilities due to the cost of doing business, so what do you mean by that? They're not getting reimbursed for their cost of doing business, so it doesn't pay them to stay open? Or how's that? Explain that to me, if you would. I know that we are understaffed at your department. Perhaps the state is understaffed for supervision, review, accountability. But I'm wondering, the private sector is closing facilities because they can't get reimbursed. Or can you explain that?
For the record, Marla McDade-Williams. So again, anecdotally, what we have heard is that they can't hire nurses, right, because of the cost of hiring nurses. So they can't manage their staffing either and make it profitable or even break even. That's what I've heard anecdotally. And I can tell you there are private sector facilities in the state, a completely different issue, but with the complex needs that we are facing with some kids, they won't accept kids with very complex needs. So even if they accept the reimbursement level, they won't accept the kids with very complex needs. We end up looking out of state for some of those youth, and if that facility will not accept Medicaid, then we're doing single case agreements with them. And I think you heard Administrator Weeks talk about that earlier about the cost of those single case agreements. They're not coming in anywhere close to what Medicaid reimbursement is going to come in at. So these are very difficult decisions, and at some point very expensive, to provide care for. We, again, as a safety net provider, I can't take everybody in Desert Willow. I can't take everybody in all of our facilities. We're, just due to the comprehensive nature of some of their behaviors. And, so we have to figure out some other solutions to some of those things about how do we distribute the workload, or not workload, but distribute the care of these youth so that we aren't overburdening one provider more than another. I think those are real issues for us all to deal with.
Right, and thank you for that, because I definitely appreciate that. As a medical director for a long-term care hospital that I'm still the director of, we can't accept all the patients that Medicaid would want us to accept, because we can't do the services that are required of that. And I certainly understand that from a behavioral health issue for children, even though I know questions earlier were asked about why aren't these facilities accepting these kids, and even if we could do 80% of it, still legally from a healthcare standpoint, if we don't have the services that are required, we can't take them, and whether you're young or old. And I think a lot of folks don't understand that the services just aren't available there. And so thank you for making that clear.
Thank you so much. Committee members, any other questions? All right, I think we're good for now. Let's go ahead and move on to our next presentation from Clark County, and then we'll have Washoe County as well.
Okay. Good afternoon, committee. Jill Morano, Director for Clark County Family Services. I have a hopefully fairly quick PowerPoint to go through to just give you a little bit of information about what we are experiencing here in Clark County within the child welfare system. So the first slide, just for your information, this is really taken from the SAMHSA continuum for mental health care. So when we're talking about what's the continuum from least restrictive to most restrictive mental health care, this is the continuum that we're looking at. And so if you look at that continuum and look in the three areas that we've identified as being the most significant areas where there's significant gaps are the ones listed here: the intensive in-home services, early screening and services, and community-based residential treatment. Some of this has been spoken about earlier today about these areas also being gaps. One of the things I did want to highlight on this slide is the number of children that have been relinquished to Clark County Child Welfare solely for the reason of needing access to mental health or behavioral health services, not due to any abuse and neglect. We have seen a little bit of a decrease in this last year, so that's good news. One of the priorities that we thought maybe this committee might be interested in considering is the need for data. This is something that has been talked about at the Nevada Children's Commission. When we are trying to develop or build services, how much of what we need often becomes a topic of conversation. And so the Nevada Children's Commission has identified these three overarching areas as areas where we really need more data to understand what the availability is in the community and what the actual need for services are. As we shift real quickly into the foster care continuum, you see set up sort of like the mental health services continuum. We have our ideal placement being the relative and fictive kin to our most restrictive being psychiatric hospital. And of course, for Clark County, we have Child Haven, which is our emergency shelter where children often start out their foster care stay. And on this slide, you can see what we see as the unmet need. And one of the things I want to highlight here is that we aren't looking at huge numbers. So like qualified residential treatment program that I'll talk about in a minute, we're looking at an unmet need of probably 40 beds. For psychiatric residential treatment facility and psychiatric hospitals, it's 20 and 10 beds respectively. So if you look at what the actual need is and what we're seeing, it really seems to be a solvable problem, because it's not like we're looking at, oh, we need hundreds or thousands of these kinds of beds and resources. When we don't have access to those kind of resources, what we're seeing is a lot more kids sitting in Child Haven with significant behavioral and mental health needs. What we have done in the last couple of years is really had to enhance our mental health and behavioral health services at Child Haven. And you can see here, as we have increased our number of child well-being visits and as we added clinical staff to our emergency shelter, our direct admissions to acute hospitals went down by 53%. And so we're encouraged. I think what this shows is those early interventions and those community-based services work to keep kids out of the end of the system. And so we've seen that just, in sort of a microcosm of looking at it just in Child Haven alone. These are just some of the referrals and resources that we provide specifically to children in Child Haven, but also to all kids in foster care in Clark County. I wanted to highlight the 518 children referred to Healthy Minds for outpatient therapy, because what's different about Healthy Minds than other outpatient providers is that we have a contract with them, so we pay them in addition to what they're getting from Medicaid, and that additional funding is necessary, particularly for kids in foster care, because they do some of that care coordination that was referenced earlier in the day. And so some examples of things that Healthy Minds does that a regular outpatient therapy provider is not funded to do is things like come to court and talk about what the child's needs are, or preparing specific types of reports for court, or even participating in child and family teams and having to negotiate the bigger number of adults that are involved in a child's life when they're in foster care. And all of that ends up costing a provider more. So it's hard for us to find services specifically in the community that can meet the bigger need when you're working with aunts and uncles and biological parents and caseworkers and independent living workers and children's attorneys and all of those other people that are involved in a child's life. So I mentioned the QRTP earlier. It's Qualified Residential Treatment Program. This, we believe, is a really needed solution to one of our problems. This is sort of an intermediate community-based, what we would have historically thought of as more of a group home model, but it's for children with behavioral mental health concerns. But what we're trying to do is keep them out of the more restrictive hospitals and keeping them in more of a community-based setting. So the federal government has identified some guidelines and criteria around qualified residential treatment programs. We are working on developing, and we've kind of developed 2 in Clark County thus far, but they don't have a sustainable funding mechanism at this point. The last 2 of the higher end of the spectrum that I wanted to highlight so you can see some of our numbers and where we are with placing children in psychiatric residential treatment facilities or the highest level of care, the psychiatric hospitals. And you can see some of our numbers have really decreased over the years. I don't know that that's necessarily a good thing. I think one could look at the numbers and say that's great, they're being treated in the community, but the alternative is really they're not getting treatment at all. They're sitting in detention or they're sitting in child haven. Right now, I did do a little bit of digging this morning, and we have identified 7 children between Child Haven and Clark County Detention right now that are sitting in those 2 facilities because we don't have a residential treatment facility for them right now. And like I said, the number is small, which actually means it's solvable. Not that there isn't a problem, but I think that it really is there's a way to get to this solution. Some of the times when we see our kids that are sitting in care, specifically the reasons that they're not able or not approved for placement in the current facilities tends to be aggressive behavior or developmental delays and developmental needs. So when we look at what we need in those additional 10 to 20 beds that we need in each of these levels of care, we're really looking at specialized beds that can handle children that are aggressive and children that are maybe lower functioning on their IQ or have other developmental delays. So as far as our policy recommendations, not a new one. Recruit and develop the mental health workforce, definitely a need. I don't need to talk any more about that, I don't think, today. A couple of statutes that we wanted to highlight as something to consider is in 433B, the statutes that cover children's mental health. It's very permissive in nature who's providing the services and what services must be provided. So potentially some clarification around that would resolve some of this ambiguity and some of the time that children end up spending in child haven or detention because we're waiting to resolve whose responsibility it is to find a need to meet the needs of the child. The same thing goes with Chapter 62, which is the juvenile justice statutes, because when children are committed to the state, they're committed for the purposes of placement, whether or not they go correctional or whether or not they go mental health, and making that decision can create some delays, and we see children sitting in detention for longer periods of time while that decision is made. And with that, I can take any questions.
Thank you. I'll take the first question. With the last 2 policy recommendations, specifically on 433B or Chapter 62, do you know which section specifically you're referring to? That would be helpful, I mean, just for context for us.
I can, Jill Moreno for the record, I can provide that later. I don't have it written out right now.
Oh, okay. But there are sections that you would like for us to review specifically that you have already outlined within your team internally, correct?
Jill Moreno for the record, yes, that's correct. We know exactly where they are.
Okay, thank you. Committee members, any questions? Let's go to Assemblyman Nguyen.
Thank you, Chair. Director, I just want to touch on a little bit of the timeline. On the slide, it says federal standards. It says aftercare support for 6 months, and then I noticed that there's some 90 days language around there. What happens after those time frame? Are there Nevada standards that we follow, or it's kind of like, okay, good luck after 6 months?
Jill Moreno for the record. At this point, there are no standards specific in Nevada for continued services. These are the requirements that are required by the federal government if we want to seek the 4E reimbursement, which is a child welfare funding reimbursement. And so this is as far as they have gone, and we have not developed anything further in Nevada.
So then what happens to that families after that 6 months after you give them the family support care? Then what do they do after that?
Jill Moreno for the record. So we don't have any families in that point yet because this is so new, but ideally they would be going to an outpatient provider, and that outpatient provider would be assessing with them what is required or needed after that 6 months. If they are covered by insurance, their insurance would be able to pick it up. If it's an insurance required or insurance approved service. But as of right now, this is the services that's required to be provided through the 4E funding, or for the funding that the QRTP, that residential service, is providing.
And any of your policy recommendations linking to the time frame that it requires for us to, because you were saying, some of the ambiguity in terms of the length of time, and also looking how to truly clarify some of these, questions. Do you think that has anything to do with your policy recommendation as well?
Jill Moreno, for the record, we have not previously considered that, but I do think that those make good sense.
Okay. Yeah, I would love to hear your thoughts on that just as we go along with this, because I think it does matter, as if we have all these temporary time frame and then people are like, well, these things are not temporary, right? It's going to be with these children for a long time, and we don't want to not clarify it all the way. So thank you. Thank you, Chair.
Thank you. Assemblywoman Brown-May.
Thank you, Chair. Thank you for your presentation. I just have one clarifying question. On slide number 6, you talked about clinical child well-being visits. And those are up 279%. So first, congratulations, right? Really good work. But I'm curious to know, is that specific to just the kids at Child Haven? Do you go out once a child has been perhaps reunited with a family or placed in foster care? How does that visit continue, or does it end?
Jill Moreno, for the record, thank you for the question. These numbers here are solely applying to Child Haven. We have made some very new, so I don't have any data yet in this presentation, some new structural changes within family services, and we have now reassigned mental health counselors to each of our geographic zones so that they have children that they're specifically assigned to manage those mental health services for. So we are hoping that helps do some of those things that you just referenced. Right now, it's not routinely happening because they're just getting their mental health services from whatever outpatient provider they're going to.
Thank you. Senator Nguyen.
Chair, I have a couple. Is that okay? Okay, thank you. I'm looking at the 233B, and you're talking about, some permissive or ambiguity. Are you referencing the fact that right now, as it currently stands, Clark County and Washoe County are responsible for these child welfare needs? And are you suggesting that the state should be responsible for it? What are the specific suggestions that you're making in this policy recommendation?
Jill Moreno, for the record, yes, so this is related to the for provision of children's mental health services. So the statute there's some lines in there such as the Division of Child and Family Services may provide services, or they may provide a residential program. And so our recommendations would be to clearly state that they are the ones responsible to providing a residential program. And this could potentially also fall in line with some sort of language like a no eject, no reject, although I don't know that we would recommend being as declarative as no eject, no reject, because we want to make sure that children are in an appropriate placement. Other states where we've seen similar kind of language has been something like the practice would look like if we refer a child to a residential treatment facility, and that residential treatment facility should be able to meet the needs, but they say no, they are responsible to find a like setting for that child, not that that responsibility goes back to like the child welfare agency in this instance. So that's how that's like an example of how we've seen other states kind of manage that no eject, no reject language. So we don't want children staying in placements inappropriately or where their needs aren't getting met just because they can't eject or reject a child, but we do want assistance in helping make a placement into an appropriate setting.
And so you had mentioned that you have 7 children right now, which obviously is something that is solvable, but it's probably 7 children is just still too many. How long have those 7 children that obviously need highly specialized care that they are not receiving because they are either in a detention facility or child haven, how long have they been in this limbo?
Jill Morano, for the record, I'd have to I can get back to you with the exact length of stays for all of the children. Right now, off the top of my head, I know one has been there a few days and another one has been there a matter of months. I don't know all of them off the top of my head, but I can get that for you.
And then I guess my other question is, Chair, is it okay if I ask again? My other question is in line with this no eject, no reject kind of, policy consideration. Arguably, it would be better for any one of these 7 children to be in a facility, anything but child haven or a detention center. Is there something that prohibits these other facilities from taking these kids other than saying, we can't take care of them because their needs are too high? It seems like it's maybe not perfect, but it's way better than a detention center or we're treating children in the same way that we already treat adults, which is unfortunate as well, in our detention centers or in child haven. So is there something that prohibits like a Desert Willow or some other agency to take these children? Sorry, that was a bit rambling. I hope.
Jill Morano, for the record. No, I think I understand the question. I would say from our experience in Clark County, we hear there might be a waiting list. There maybe there's like a milieu issue where they don't believe a child would fit in well with some of the other children in the facility. It may be that the services they don't feel would be the services couldn't meet the child's needs, like maybe there's a need for applied behavioral analysis, and historically we have not been able to access applied behavioral analysis when the child is in a residential treatment center. Ms. McDade-Williams addressed that earlier, that is something that we're working on a solution for right now. But I would say those are kind of some of the big things that we hear for reasons for denial on the child welfare side. I don't know if the facilities might have additional information.
And I don't know if Ms. McDade-Williams is still available and maybe have answers for whether or not they are prohibited from taking these children while we're looking for a better scenario.
For the record, Marla McDade-Williams.
Thank you.
Desert Willow right now has a 90-day waiting list. We're up to full to capacity at this point. So it's not that we're prohibited from, but we, as Senator Titus talked about earlier, we have to ensure that we can provide safe services, applicable services to the youth that we're taking. And so if I am working at a staffing vacancy, which right now is the issue in our detention facilities, we are performing significant overtime just to maintain the youth that we have. It's not that we don't want to take them, but really our staffing capacity is the biggest limit that we have. There's no prohibition. But again, I have, one youth who came in at a 4-to-1 ratio and doesn't want to be anywhere. And we've gotten her down to a 1-to-1, but, she has significant needs. and I get pressure, well, get her off the one-to-one. Well, you know what? I'd love to get her off the one-to-one. But doing so could mean that she ends up killing herself. So these are not easy issues that any of us deal with at any given time. Those are the decisions that go into all of these decisions for placement. I know that people think they're arbitrary, but they're not. And, you saw the list. I have Desert Willow, I have PRTF North. We tried to contract out to another facility for Oasis, and I have one vacant residential treatment facility. If I had staffing today, I'd have people in there. But, as the legislature has already made decisions looking at our staffing, that, we'll try to contract this out and see if you can be more successful that way. These are significant limitations for us. I can't compete with the private sector in hiring, and I've already said the private sector has closed down beds. So here for any solutions, but none of these are arbitrary decisions that we're making on admittance for these youth. And courts get frustrated with us as well. We do our best, which is why we stood up ABA services in a residential facility, trying to respond to that expectation in the community. We are, Dr. Wade has identified, we used to have a juvenile sex offender program in Desert Willow because that was a need. And then for whatever reason, the community decided that they didn't want to use those services in that facility anymore, so we no longer do that. I have had a thought running around in my head recently that if I make Desert Willow only open it to youth through child welfare and juvenile justice, then all of the private sector providers whose insurance is inadequate to provide coverage out in the community will then be left without anybody to treat their needs. Medicaid is a payer in the system. We take significant Medicaid kids outside of child welfare and juvenile justice. If I limit all of my admittances only to child welfare and juvenile justice, then where do those Medicaid kids go? So these are very real issues, and looking forward to continued discussion and trying to figure out how we resolve all of those issues.
Thank you. And more of a comment, I guess. It's just concerning that obviously we have difficulties on all ends and all areas within this system. But I have to believe that there has to be some sort of something that's better than a detention center or child haven. How many of these kids end up in emergency rooms or hospitals because we know that the employees that are at child haven are not trained to deal with these type of medical and complex cases. So thank you, Chair, for your time.
Thank you. Let's go to Senator Titus.
Thank you, Mr. Chair. First, a comment and then a question. So, again, I recognize and I understand your limitations, and it's all about staffing, and the one-on-one is just huge. I mean, if in my own facility, if I accept a patient that is somewhat disruptive or escape or confused or combative, then that requires one-on-one when we have limited staffing, and that's to the detriment of the rest of the patients. And so it's not that simple that you just find a bed. We have the bed. Yes, there's a blank bed, but there's not the personnel, and it puts other people at increased risk. So I can't emphasize enough how important it is that you hold steady and make sure, it's easy to be pressured. Oh yeah, take these folks because they shouldn't be in jail. But the reality is, you have to also take care of the people that you've already accepted there, and the risk for everybody. It's just not that easy, unfortunately. Now the question, page 10, this is for Clark County, so I'll take the state off the hot seat for a second. Back to Clark County with this presentation on page 10. They talk about some policy recommendations. And one of the policy recommendations, because we are trying to find solutions. The chair of this committee has made it very clear we want to come up with some possible BDR, some true solutions that we can offer. And one of the recommendations you say is address the length of time required for professional licensure. Is there any particular licensure group or subgroup that you have identified? Because I hear anecdotally from medical doctors and how long it takes and sometimes nursing, but that's just like a big, broad paintbrush there about professional licensure, because we have a lot of healthcare licensures in our state. Is there any particular groups of licensure that you've identified that has more than anything else that is the delay?
Jill Morano for the record. Yes, when we wrote that, we were specifically referencing concerns that we have seen internally with our licensed clinical social workers and our licensed marriage and family therapists, and the amount of time that it takes for them to get their clinical hours so that they can get their licenses.
So are you aware of any state compacts regarding those two particular licensures that we could address to help with that?
Jill Morano for the record. We didn't look at anything that other states are doing, but when we were reviewing the statutes, some of the restrictions around how the hours can be earned to get your clinical hours seems to be the thing that is a barrier. So I'd be happy to provide a little more detail around some specific changes that we would see that could be helpful in that area.
That's excellent. I'd love to see that. I'm sure the committee would like to also, but as we start looking at some of these BDRs, I think that's the kind of thing that we can get really some concrete changes in. And if there's that kind of simple stuff like hours or something that we can do to address this, that's what we need to hear. So looking forward to that information. Thank you. And thank you, Mr. Chair.
Thank you. Any other questions? So I just want to take this moment just to like digest the content of these presentations to this, like so far, right? Okay, so in the last, so I already asked about the two policy recommendations of pointing out the NRS. So, and